Hello, hello, mic check. Hello, hello. Hello, mic check. Hello. Hello, hello, mic check. Hello. Hello. Hello, mic check. Hello. Hello, mic check. Hello, hello. Hello, mic check. Hello. Hello, mic check. Hello. Hello, mic check. Hello, hello.
करेंगे है ना वो तो सौखा है वो तो सलमी ਨੂੰ ਫੇਲ ਕਰਦਾ ਯਾਰ ਮਿੱਤਲ ਮੌਲ ਨੂੰ ਫੇਲ ਕਰਦਾ ਤਾਂ ਬਾਹਰ ਘੰਟਾ ਹੈ ਦੂਜੀ ਫਿਲਮ
Hello. Hello, mic check. Hello. Hello, mic check. Hello.
ਇਹ ਤੇ ਸਲੋ ਮੋਸ਼ਨ ਨਹੀਂ ਚੱਲਦੀ ਯਾਰ ਸ਼ਾਰਟ ਸਲੋ ਮੋਸ਼ਨ ਹੋਊਗਾ ਸਲੋ ਕਿਵੇਂ
Hello, mic check.
ਤਾਂ ਆਪ ਕਰਨੇ ਪਊਗਾ ਆ ਉਹ ਤਾਂ ਨਹੀਂ ਹੁੰਦੀ ਨਾ ਨਹੀਂ ਜਿਵੇਂ ਆਹ ਛੋੜ ਜਿਵੇਂ ਇਹ ਵਾਕਈ ਰਨਿੰਗ ਚ ਆਊਗਾ ਕਿ ਦਿਖੂਗਾ ਆਪਾਂ ਨੂੰ ਇਹ ਬਸ ਦਿਖ ਸਕਦਾ ਹੁਣ ਰਨਿੰਗ ਚ ਨਹੀਂ ਆਉਂਦਾ ਨਾ
Wait.
ਇਹ ਤੇ ਗਾਰਡ ਲੱਗਿਆ ਪਿਆ ਇਹ ਮਿਲ ਜਾਂਦਾ ਗਾਰਡ ਹਾਂ ਹੈਗਾ ਤੇਰੇ ਕੋਲ ਲੱਗ ਜੂਗਾ ਇਹ
Hello, mic check. Hello, hello. Hello.
ਉਹ ਵੀ ਕਰਿਆ ਰਨਿੰਗ ਵਾਲਾ ਤਾਂ ਫਿਰ ਬਾਈਕ ਤੇ ਹਾਂਜੀ
Hello, hello, mic check. Hello.
भाई बैटरी की जेब च पाना बैटरी की जेब च पाना पावर दा पाना कि बैटरी तो बैटरी तीन पाना जेब च दो पाना वो आप समान चकना सारा उत्थे फिर मैनू बैटरियां कढ लैन देख रहे जी
Hello, mic check. Hello. Hello. मेरा फोन उत्ते पे हैगा
जय श्री राम सर। मैं आ रहा हूँ, बाहर बाहर आ रहा हूँ।
Six, strengthening the medical fraternity and serving society with dedication.
We are honored to have with us eminent speakers and respected leaders whose wisdom and experience will surely inspire and guide us.
आज ਦੀ ਇਹ ਕਾਨਫਰੰਸ ਸਿਰਫ ਇੱਕ ਅਕਾਦਮਿਕ ਮੰਚ ਨਹੀਂ ਸਗੋਂ ਤਜਰਬੇ, ਗਿਆਨ ਅਤੇ ਵਿਚਾਰਾਂ ਦੀ ਸਾਂਝ ਦਾ ਸੁੰਦਰ ਮੌਕਾ ਹੈ।
ਪੰਜਾਬ ਦੀ ਧਰਤੀ ਹਮੇਸ਼ਾ ਸੇਵਾ ਤੇ ਸਮਰਪਣ ਲਈ ਜਾਣੀ ਜਾਂਦੀ ਹੈ ਅਤੇ ਅੱਜ ਦਾ ਇਹ ਸਮਾਗਮ ਉਸੇ ਆਤਮਾ ਨੂੰ ਦਰਸਾਉਂਦਾ ਹੈ।
On behalf of the entire organizing committee, I, Sukhnur,
And I, Upneet Kaur,
third year MBBS students at IIMS Bathinda, extend a warm welcome to all the delegates and wish you a highly enriching and successful experience.
we begin today's academic proceedings with a first scientific session titled Arthroscopy Application in Sports Medicine and Orthopedics. To chair this session, we are privileged to have with us three eminent personalities, Dr. Rajesh Badyal, Dr. Pankaj Sharma, Dr. Deepak Bansal. May I respectfully invite our esteemed chairpersons to kindly take Thank you, sir. Now, it is my pleasure to introduce our speaker, Dr. Ajay Gupta, a respected expert in arthroscopy and sports injury management. Arthroscopy has significantly transformed orthopedic practice through minimally invasive techniques and improved patient outcomes. Sir, we are honored by your presence. Please take the stage.
Good morning, chairpersons, my senior colleagues and friends. I will be speaking on applications of arthroscopy in sports medicine and orthopedics. Arthroscopy is a minimal invasive keyhole surgical procedure used to diagnose and treat joint problems using a small camera and specialized instruments inserted through tiny incisions. Arthroscopy evolved from 19th century cystoscopy to become pioneering keyhole surgery to reduce patient recovery time. Initiated by Kenji Takagi and advanced by Masaki Watanabe, with refined cameras, it transformed from diagnostic to therapeutic use, becoming standard orthopedic procedure. Arthroscopy used to visualize, diagnose and treat joint problems. Once usually used primarily for diagnosis, it has evolved into a sophisticated tool for numerous orthopedic conditions. The key advantages of arthroscopy are the smaller incisions, usually 3 to 4 millimeter in size, is faster recovery due to less trauma to surrounding muscles and healthy tissue. Patients recover significantly faster. There is reduced pain and inflammation due to minimal disruption of joint structures, and there is lower post-operative pain and swelling. There is low risk of complications because small incisions, the limited exposure of internal tissues to bacteria and hence reducing the infection rate, and there is less blood loss. This enhanced diagnostic accuracy due to high definition cameras. Surgeons are able to treat minute tissues that may be missed by MRI or X-rays. Outpatient convenience. Most orthoscopic procedures can be performed outpatient, and patient doesn't have to stay in the hospital. Common clinical use of diagnostic evaluation, which the problem which can be missed by the MRI or X-rays that can be diagnosed. Tissue debridement to trim the damaged cartilage to smoothen out the movement of joint. Reconstructive surgery of ligaments and tendons using special implants and grafts. Removal of loose bodies. Fracture fixation in certain fractures. So there are numerous indications in knee. We will discuss one by one. ACL injury is the most commonly injured ligament. In the United States, 4 lakh ACL reconstructions are performed annually. In India, 1,25,000 were being performed in 2018. Now the number might have risen a lot. So the mechanism of injury is when femur is in adduction, knee in abduction, and ankle is in eversion. And if a dynamic valgus force is applied, the ligament ruptures. The common symptoms are audible pop in the knee, rapid swelling due to internal bleeding, severe pain in the joint line or the center of the joint, feeling of the knee if the knee is loose or is buckling under your weight, the loss of range of motion due to pain and swelling, and there is difficulty to bear weight on the affected leg. ACL reconstruction is surgery that replaces the torn ACL with a tissue graft, usually hamstring or tendon, to restore the knee stability and function. A meniscus tear is a common knee injury involving the rupturing of the C-shaped ligament, which is shock absorbed between the femur and tibia. Common symptom of swelling develops late in this situation. A popping sound may be heard. A mechanical locking sensation or a knee giving way sensation may be there. The classification of the tears may be according to location, shape or zones. The treatment of meniscal tear is removal of the damaged meniscus tissue, which is meniscectomy, or repairing the meniscus, which may be a inside out, outside in, or a all inside technique. A posterior cruciate ligament tear is the rupture of the strongest ligament of the knee. Most commonly is the dashboard injuries, which may be due to direct impact, sports collisions, or hyperextension. Symptoms are dull knee pain, swelling and stiffness, instability, and difficulty in walking. A PCL reconstruction surgery is done arthroscopically, where a soft tissue graft is used to reconstruct the PCL. A cartilage lesion is localized damage to the articular tissue, usually caused by acute trauma due to sports injuries, falls, or direct blows. A repetitive microtrauma in high impacted fields. A mechanical issue may be malalignment of joint, or underlying condition like osteochondritis dissecans may be a reason. Symptoms are localized joint pain, swelling, stiffness, mechanical symptoms like catching, locking, and feeling of knee giving way may be there. The treatment of cartilage lesions is debridement and microfracture, where small holes are made so that a fibrocartilage appears and the blood supply appears and the fibrocartilage is made. Or a mosaic-plasty, where healthy hyaline cartilage from non-articular surface is implanted into the lesion, or an autologous chondrocyte implantation, where a small piece of cartilage is taken and cultured in the lab and re-implanted in the lesion. Newer techniques like means cartilage implantation as a one-step procedure, where a small piece of cartilage is harvested and minced and implanted with the help of fibrin glue, or in situ polymerizable hydrogels are being used. Loose bodies are small fragments of detached bone or cartilage that float freely in the joint space. They may cause locking, sharp pain, mechanical symptoms, or swelling or stiffness. Usually caused by traumatic injury, degenerative disease like osteoarthritis, osteochondritis dissecans, synovial osteochondromatosis. The treatment is by arthroscopic removal. Synovitis is inflammation of synovial membrane, which the fluid is excessively produced and there is a swelling of the knee, Common symptoms of joint pains, swelling, warmth and redness, reduced range of motion. It may be caused by rheumatoid arthritis, gout, psoriatic arthritis, osteoarthritis, overuse, an injury or transient synovitis or an infection. The treatment is by arthroscopic synovectomy using multiple portals. Shoulder joint has numerous indications. Recurrent dislocation of shoulder joint causes a Bankart lesion, which is detachment of the labrum, and hill sac lesion, which is bony defect in the humeral head. Arthroscopic repair of the detached labrum, Bankart surgery and attaching of the infraspinatus into the hill sac lesion, which is remplissage, is done to treat the instability. Impingement syndrome is a clinical condition where tendons of rotator cuff and the bursa become painfully in the acromion during arm elevation. The symptoms are painful are in 60 degree to 120 degree of abduction, difficulty in sleeping, gradual loss of shoulder strength and mobility, sharp overhead pain in overhead activities. Treatment is by arthroscopic decompression or gumuloplasty using a burr, inflamed bursa and bony spurs are removed. The rotator cuff is a group of muscles, of 4 muscles and the tendons that surround the shoulder joint. It functions like a sleeve to hold the head of humerus firmly in the shoulder socket, providing stability and the strength needed to lift and rotate your arm. A rotator cuff tear can be caused when one or more tendons of the shoulder joints are injured, and it causes weakness of the shoulder and difficulty in activities of daily living. It may be classified based on its thickness, which is standard classification, or shape, retraction or delamination pattern. Treatment is by arthroscopy by using suture anchors. The detached tendons are attached to the bone. The slap tear is superior labral tear where the biceps attaches. It is caused by throwing action or a fall on the shoulder. It causes a deep shoulder pain, mechanical symptoms like catching, popping, or catching sensation or clicking sensation. It causes weakness of the shoulder, a dead arm sign when throwing activities. Arthroscopy repair is done using suture anchors. The detached labrum is attached to the bone. The long height of biceps may be frayed or partially torn or completely torn. The common symptoms of Popeyes deformity or inaudible pop or pain or weakness may be there. Treatment options, it's generally reserved for athletes or manual laborers. Biceps tendinodesis is done, which is reattaching the tendon to the bone using special anchor sutures or screws. Adhesive capsulitis, commonly known as frozen shoulder, is a painful condition. The joint becomes thickened and stiff and inflamed. This leads to significant loss of motion. Common risk factors: diabetes, thyroid disorders, immobilization, or age between 40 to 60. The management is, if the conservative management fails, after 6 to 12 months, manipulation under an anesthesia or an arthroscopic release using a radiofrequency device or a cutting instrument can be done. There are numerous applications in ankle joints. Commonly are retrocalculum bursitis, ankle impingement, osteochondral lesions, loose bodies, synovitis, instability, arthritis, and fracture management. Impingement of talus and tibia is dealt with arthroscopically and a decompression is done. Arthroscopic treatment of osteochondral lesions is done by microfracture, ACI, mosaic-plasty, or means cartilage implantation. Indication in elbow are loose body removal, the most common indication, and debridement in osteoarthritis, release and debridement of ECRP tendon in tennis elbow, treatment of osteochondral defects with microfracture debridement, arthrolysis, releasing of scar tissue to regain motion in a stiff elbow, synovectomy in an inflammatory arthritis like rheumatoid arthritis, or irrigation of bone ligaments and TFCC, ganglion cyst excision, fracture, assisting in fracture reduction of distal radius of scaphoid fractures, septic arthritis, irrigation and debridement of infected joints, which often leads to shorter hospital stays. Synovectomy can be performed in rheumatoid arthritis, loose body removal, and carpet release can be done. So take-home message is arthroscopy is a versatile technique used to address variety of joint conditions. It is minimally invasive. It can alleviate pain and disability and help one to return to his sports or work. Thank you.
Hello. Thanks, Dr. Ajay, for a practical talk, wonderful knowledge of arthroscopy.
Very useful talk by Dr. Ajay, but any question from the audience, because it is typically orthopedic topic, but the problems are general, like ankles. Even we are doing ankle sprain arthroscopy nowadays, which is very commonly managed conservatively in past. So, sir, what is your experience for ankle sprain arthroscopy?
In ankle, I don't have any experience in dealing with ankle sprains, but I have done like loose body removals and microfractures in ankle cartilage lesions. But till now, I don't have any experience of ankle instability.
Nowadays, ankle arthroscopy is very in trend, because like even retrocalcium bursitis.
That I have done. Retrocalcium bursitis we have been doing regularly, and maybe I have done 30 to 40 cases with very good results.
Even TA repair we can do nowadays arthroscopically.
Tendon arthroscopies are now coming up.
TA repair now in Europe it is very common nowadays.
Even in tenosynovitis, they are doing tendon sheath arthroscopies to deal with the tenosynovitis.
And again, arthrodesis of ankle also from arthroscopy.
Yeah, sure. That I have mentioned in the slides also. In arthritis, arthroscopy assisted ankle fusions are being done, and they are equally good as open surgeries.
Even very small joint of hand and foot, there is also scope of arthroscopy nowadays. And people are doing, because like synovium's number of joint in rheumatoid arthritis, so people are debriding the small joints by very small cannula and very small arthroscope. It is very good procedure. Thank you, sir.
Thank you.
Thank you, sir, for that enlightening and insightful presentation. Now, I would request our esteemed chairpersons to kindly felicitate our speaker as a token of appreciation and gratitude. Thank you, sir. Now, I would like to request Dr. Amrit Gupta to kindly present a token of appreciation to our respected chairpersons for guiding and chairing this session. Thank you once again to our speakers and chairpersons for an academically enriching session. We truly appreciate your valuable time and contributions. Now I would like to request my colleague Bhav to take over the podium.
Thank you, Puneet. Good morning, everyone. Myself, Bhav Brad, third year MBBS student at AIIMS Bathinda. I would like to welcome the chairpersons for the next session, Dr. Raman Garg and Dr. Gajendra Singh Bhatti. Please, sir. Now, with great enthusiasm and respect, I would like to welcome our next guest speaker, Dr. Sonali Mondkar-Katpal ma'am. Ma'am will be addressing us on the topic management of gastrointestinal stromal tumors. Ma'am, please.
Hello. Very good morning to everyone. I am Dr. Sonali Mondkar. I mainly have done my super specialization from Asia. Surgeon's perspective. So, there's cancers. That is GIST. You have a big spectrum as far as these tumors are concerned. So most of them are in the GI tract. So most common site being the stomach, which takes around 60%, followed by the small bowel, 30%, the colorectal come later. Now, GI tract is as good as 90 to 95%. We have 5% which are extra-intestinal. That is, you'll have in the retroperitoneum, the mesentery, the omentum. That's where we usually have these. The presentation, as far as most of the patients who come, they have been detected incidentally. That is, they do routine investigations. These days, ultrasound has become a modality which every patient subjects to ulcerated. But if the patient has presented with an upper GI bleed, yes, you can have a small ulcer there. But see how well defined the structure is. Vis-a-vis a cancer, which will be ulcerated, a bad ulcer with slough, with craters, loss of rugae in the stomach. That is how a cancer looks. Now, if you see the next slide, this is the okay. So this is the lesion. They are usually submucosal. This is the stomach. So this is the lesion which you can see. It's a very homogeneous lesion. But like I had said before, there can be places where you can have large. They can take a 20 to 30 centimeter size. And if you see this, the entire area, that is a heterogeneous structure. Because heterogeneity is on basis of, because there will be blood, there will be some amount of fluid, there will be some amount of fat densities, necrosis which will be taking place in such a tumor, as a result of which you will have these. Now these tumors characteristically usually do not invade, which is a feature of cancers. They usually push their boundaries, they will push things aside. So that's why they are considered to be less aggressive as far as cancers are concerned. But however, the high-risk features, that is if they are infiltrating, they are having lymph nodes, or they are having certain features, heterogeneity, that can sometimes be a high-risk feature. Now, one of the upcoming diagnostic modalities, what is the role as far as EUS as well as PET scan is concerned? Now, EUS is a very good modality, especially when you have very small lesions to characterize them, usually less than 2 centimeters. You can, even if patients have no high-risk features, this is internal vascularity, heterogeneity, cystic spaces, these patients who have lesion which is less than 2 centimeters even can be kept on follow-up. But one of the most important benefits of EUS is a guided biopsy, a FNA, which is mandatory at some times. And the plus points are, when you do a percute biopsy, the chances of tumor seeding is more, but endoscopic guided biopsies do not give you a tumor seeding potential. The other important scan is a PET scan. Now, many times, like the picture I've shown you before, huge tumors, the surgeon's dilemma is whether I should go ahead and operate or probably I should downstage. Now, why downstage? Because these tumors usually can result in organ preservation surgeries. They are not aggressive. They are not cancer surgeries. You do not need to take a huge margin to excise, which means that if this tumor is located at the esophageal end, or if this tumor is located at the rectal end, You do not need to subject the patient to an abdominoperineal resection, where you're, as a result of which you need PET scan. Why? Because sometimes these are at borderline. They are huge. You know that if you do not act, probably the ability to resect them, you might lose that window. So you get a baseline PET before starting. Most common therapy here is tyrosine kinase inhibitors, that is imatinib therapy to downstage these tumors. You do a PET, you start your therapy. You can repeat the PET as soon as 2 to 4 weeks, that is within 1 month, for a rapid readout to know if the metabolic activity is improving. That will help the surgeon, the oncologist, the multidisciplinary team to sit and discuss whether we can wait and downstage the tumor further so that we can subject the patient to a less aggressive surgery. If it shows that there is no metabolic change, then you have to go and do the surgery. That is one of the important indications of PET. The other being, one is that sometimes in recurrent tumors, patient has been operated before. You want to differentiate between active tumor and a scar. And one of the common things is when there is a ring-shaped uptake on a preoperative PET, it has been seen the chances of recurrence increase in such cases. As far as role of preoperative biopsy, yes, it is not absolutely mandatory. We will consider it absolutely mandatory when you are subjecting the patient to preoperative therapy, that is imatinib therapy, then yes, you require. But if you have a tumor where you can go ahead with resection, it is not absolutely mandatory until and unless you feel the findings can be a cancer, can be equivocal findings, then yes. But usually they can bleed, so biopsy is not mandatory. And if you're doing a biopsy, like I've said before, it will be a US guided one, preferably not a percutaneous one. Of course, if there is metastatic disease and a locally advanced tumor, then yes, you will have to go ahead with a percutaneous biopsy. Now, surgical intervention, I'll be talking mainly about gastric. So this is the stomach. The green part is where we can do a staple gastrectomy. The yellow part is where you just cut this, a distal gastrectomy, and these are transgastric procedures. Transgastric is where you can directly put the ports even in the stomach. You can inflate and you can just remove small lesions near the GE junction or along the lesser curvature, which are considered difficult tumors as far as surgery is concerned. So now, this gist can be subjected, of course, to an open surgery, to a laparoscopic surgery. Both they are amenable to. The principles of surgery remain the same. Pseudocapsule is the most important part. The capsule should not be ruptured, because that's what you're going to increase your risk of recurrence with. Secondly, one of the hallmarks of these tumors, positivity, you don't need to subject the patient to a re-resection. So these are the hybrid approaches. So hybrid is, again, that is endoscopic as well as laparoscopic. So you have legs, that is lapro-endoscopic operative surgery. You have a clean neck, that is combined lapro-endo approach to neoplasia. You have NEWS, non-exposed endoscopic wall inversion, and you have transgastric. So now all these, this is the anatomy of the stomach in general, wherein this will be the serosa, this will be the mucosa, the mucosa will be the inner part, between will be the muscle layer, and then you have the serosa. So all these techniques basically depend on one thing. You will have the endoscopist putting in the endoscope here. Most commonly that what we have done, the endoscopist puts here. Let's say there's a lesion over here. So what they do is the mucosa, they do a hydrodissection. They will inject a dye like indigo carmine or methylene blue. That causes the lesion to rise up. Now these lesions are submucosal. That's what the benefit is. So the mucosa raises up. The surgeon from outside is going to mark the entire area and excise. And then most of the tumor is by the mucosa. You just put a stapler across and then take a seromuscular layer. So most of these techniques depend on this. So if you see this, difficult to understand, but what most of the techniques do is, you have, like if you have legs, that is laparoscopically endoscopic, and then you suture. The good part about clean neck is that we are going to cut from outside. Inside also will be cut, but the mucosa remains intact. So you are going to put a stapler across, as a result of which you are not going to cause contamination. The gastric juice is not going to enter the peritoneum. You are directly suturing. NEWS is exactly the opposite, wherein the incisions will be taken on the mucosal side as well as the seromuscular side. However, the specimen will be retrieved orally by the endoscopist. So obviously the limiting factor here is the lesion cannot be more than 2 to 3 centimeters, because per oral extraction otherwise will be difficult. And coming to the post-op therapy, TKI therapy. Now studies as far as TKI therapy are concerned is basically on the risk. We usually divide these patients into a low risk, a medium, intermediate risk, and a high risk. Now, what determines the risk basically is this. What they have seen is the location, one of the very important parts. Stomach, even going up to sizes 5 centimeters, are considered good as long as the mitotic rate is less. So one is the location, one is the size, one is the mitotic rate. And if you see the picture I've shown in this next to this, tumor rupture, like I said before, if there's a capsular rupture, there are studies which show almost 9 in such cases. So this is a rough chart which tells us where we can put the patient as far as risk is concerned. Why is this important? Because your pre-op and your post-op management will depend on this. So by that I mean, now if the patient has never received any pre-operative imatinib therapy or gone ahead with surgery, or your final histopad shows, then in such cases you are going to give, especially in high risk, at least 3 years of post-operative imatinib to prevent recurrence. While if the patient has received a downstaging, he has received a pre-operative imatinib, now it's a general consensus. There are no proven studies here, but at least 2 years of post-op imatinib is recommended. As far as surveillance is concerned, imaging, yes, like any cancer, for every 3 to 6 months, for every 2 to 3 years, and then annually up to 5 years. Of course, if low risk, then you can increase the distance of imaging. If it's the high risk, then probably more frequent imaging will be required. So these are a few photos about what I had said, wherein you are cutting, you are putting in the dye, and then you are passing a stapler here and doing it. This is usually what we do as far as this is like and this was a huge tumor. This was around 20 to 15 centimeters. Thank you.
Thank you, Dr. Sonali, for the wonderful presentation. I just want to add that GIST are not very rare tumors. Very frequently we see, and mostly patient comes as a bleed. So we should be aware any patient middle age coming with upper GI bleed, it should be very quickly evaluated by upper Scopy and to be diagnosed. So anything?
Thank you so much. Thank you. Any questions from the audience?
Anyone from the audience want to ask anything? So, thank you, Dr. Sonali. Your clarity of thoughts have truly enriched us. I would like to request Dr. Raman Garg and Dr. Gajendra Bhati to present Dr. Sonali. Dr. Raman Garg is gastroenterologist at Bombay Gastro Hospital, and Dr. Gajendra Bhati is working as AP Adesh Medical College. Please. A round of applause, please. I would now request Dr. Ajit Pal Singh, ex-Civil Surgeon Bathinda, please come on the stage and felicitate our chairpersons. Dr. Raman Garg and Dr. Bhati. Second one to Dr. Raman. Thank you, sir. Now, I would request Gurpreet Singh, a student from AIMS, here take over the stage.
Thank you, sir. Good morning, everyone. Myself, Gurpreet Singh, a third-year MBBS student here at AIMS Bathinda. So now I would like to welcome the chairpersons for the next session. Dr. Baljeet Singh, Senior Radiologist doing private practice in Bathinda, and Dr. Vaibhav Saini, Head of Department in ENT at AIIMS Bathinda. Thank you, sir. Please join us on stage. Now, without further delay, I would like to welcome the speaker for the next session, Dr. Maheshinder Singh. His MD in radio diagnosis. He works as an interventional radiologist practicing currently at Kiran Intervention and Radiology Center in Bathinda. Sir, please join us on the stage.
Thank you. My topic will be on interventional radiology from basics to today era. Interventional radiology is an established radiological subspecialty which has become integral to the modern management of patients in wide range of pathologies. Interventional radiology delivers high quality, patient-focused care, which is safe and effective in both elective and emergency settings. The IR includes numerous treatment options from important routine interventions to complex innovative solutions for illness otherwise considered untreatable. Over the years, numerous IR procedures have increasingly replaced open surgical techniques as they are less invasive, with reduced morbidity and mortality rates, and allow more rapid patient recovery and early hospital discharge. Modalities used in interventional radiology are X-rays, ultrasound, CT, MRI, DS and cath labs are part of X-ray only. Each modality is selected based on target organ, procedure type and patient condition. History and evaluation of interventional radiology. In 1964, first angioplasty was done by Charles Gotter. In 70s to 80s, development of balloon angioplasty was started. In 90s, stunt and ambulatory therapies were introduced. From 2000 and present, advanced image-guided therapeutic procedures, cancer therapies, and robotic interventions are being done. Basic principles of interventional radiology are: it should be minimum flow was seen in distal ECA. Talking to angiography, a guide is introduced through a needle to get a guide map of biliary system that can be used for PTBT in internalization and externalization, or doing biliary stenting or dilation. Talking about affinity biopsy, these are the common biopsy guns that are used for the tissue sampling. This was a case of bone mass, and sampling was done from a transpedical approach, and this was a case of lytic lesion present in a like bone, and separating was done under the CT guidance. When we talk about the aspiration is commonly done under ultrasound guidance. Like this is a image showing the fluid aspiration from the pleural cavity, and this is a liver abscess aspiration done under ultrasound guidance. But yes, CT also helps in fluid aspirations. Now talking to non-vascular interventions, that is placement of PCDs, nephrostomy, biliary drainage and stenting, and pain management. When we talk about the placement of PCD, it can commonly be done in fluid collections or liver abscesses. This is a case in which we can see a PCD is placed in a liver abscess, which was done under CT guidance. When we talk about a nephrostomy, it is a percutaneous procedure in which a drain is placed between the renal pelvis under a local anesthesia in case of obstructive uropathy. When we talk about the biliary drainage and stenting, this was a case of the post-hepatogynostomy in which there was a tight stricture in the proximal part. After that, balloon dilatation was done and the placement of stent was done. And in routine, we placed a catheter for 2 days within the stent to know about the biliary drainage, if there is any blockage or not. This was the second case in which a complete abrupt cutoff was there due to a malignant stricture. Again, balloon dilatation and placement of the stent was done. This was an ultrasound guided pain management in which there was a ganglion block done under the ultrasound guided, and here we can see a needle that was introduced under the ultrasound guidance. When we talk about vascular interventions, we talk about firstly about angioplasties, stenting, thrombolysis, embolization, and endovascular aneurysm repair of aorta. In which this is a case of angioplasty in which we can see a non-opacification of the PTA. After a balloon dilatation, we can see a good flow within the PTA. In this case, there is abrupt cutoff in mid SFA. After placing a stent and a balloon dilatation, we can see a good flow within the mid SFA. When we talk about thrombolysis, there are two types of thrombolysis can be done: mechanical thrombectomy, and second is catheter-directed thrombolysis. In catheter-directed thrombolysis, catheter with multiple holes is mainly done at a very high center. A particular designed graft is ordered after the proper measurements of the aneurysm, and it is done in a precise catheter. In intervention oncology, tumor embolization, TASE, radioembolization, cryotherapies have now introduced from last 1 decade. When we talk about tumor embolization, there are commonly RFA and microwave. RFA commonly uses electric current, whereas microwave uses magnetic current. In RFA, there is more heat sink effect. For that reason, it is not used when the tumor is very close to vessels or the size of lesion is more than 4 centimeters. But when we talk about the microwave ablations, due to its less heat sink effect, it can be used when the lesion is very close to the vessels, hepatic vessels, and the lesion size is up to 5 centimeters. And this was a microwave case of microablation. In coming days, interventional radiology is upcoming in women health from last 5 years. Even in cases of adenomyosis, embolization has given a good results. IR in emergency medicine is also being used in trauma embolization, GI bleeds, postpartum hemorrhage, acute discipline in today's era. It represents future of minimal invasive medicines. Thank you.
Hello. Very good insight and the future of this interventional radiology given by, and I want to tell the audience that many of the younger radiologists now, they are in this intervention radiology doing very good work in Bathinda. So I congratulate you for this, Dr. Maheshwar.
Thank you, sir. Thank you.
Any question from the audience, please?
In the vessel, how much are the chances of getting embolus dislodged and causing respiratory?
Sir, whenever we are using CTT, that is capsular rectal thrombolysis, first of all, we put a IVC filter. Before putting IVC filter, this procedure should never be done.
Cannot be done.
No. It is a complete contraindication.
Oh, thank you.
Thank you.
Thank you, Dr. Vikas and Dr. Maheshwar.
Thank you so much, Dr. Maheshwar, for the lucid presentation. I just wanted to ask a few things. First of all, you told something about chemoembolization. So I need to ask two things regarding my specialty. For example, we need to embolize these juvenile nasopharyngeal angiofibrom or vascular tumor at the skull base. What is the typical cost? Because intervention radiology is a very good thing, but it's still out of the reach of the normal individual, or what we say, the normal kind of patient strata we cater. They are usually out of the reach. So what is the cost in private practice of chemoembolization in highly vascular lesion? For example, you have to chemoembolize IMAX, delmaxillar.
Basically, cost depends upon the size of tumor.
Okay.
Secondly, how much we can say to the patient, this is minimal, but still it will reach up to 1 lakh. Because the cost of microcapsules, when I started doing the procedure in 17 or 18, it was around about 18,000. Now it has reached to 32,000 to a hospital. And they are increasing rate every year.
But this Ayushman coming, this is not
No.
That is the problem. We have a lot of patients.
But I don't know, I should request Dr. Shada sir. Sir, they have mentioned all the procedure in neuro-intervention radiology, but not in, I am doing hepatobiliary interventions. They don't have any separate package for hepatobiliary intervention. Whatever is there, that is particularly neuro-intervention. So that is a major confusion.
These procedures are very useful for the patients, but they are not in the gambit of Ayushman, so that patients are not getting benefit.
Yes.
The next question is, do you need
Please give them a huge round of applause. Nextly, I request Dr. K.K. Bajaj to felicitate our chairpersons. Please give them a huge round of applause. Thank you for your presence, sir. Now I would like to call upon my colleague Sukhnur to continue with the session.
Thank you, Gurpreet. Let's welcome on the stage the chairpersons for the next session. Dr. Ayush Makkad, Oncologist and Director at Sri Balaji Cancer Hospital, and Dr. Seema Gupta, Senior Medical Officer at Bhakta. We welcome you, sir and ma'am. Nextly, pouring a new light, symbolizing knowledge and clarity, just as his name reflects, Dr. Navdeep Singh, Senior Consultant Medical Oncology and Hematology Oncology at Orison Hospital, Ludhiana, will be addressing us on the topic Suspecting Cancer in Routine OPD Practice. I kindly invite Dr. Navdeep Singh to take the stage and enlighten us.
Thank you so much. First of all, I would like to thank Dr. Vikas for giving me this space in his August conference. Thank you very much. The topic for today is suspecting cancer in routine OPDs. So our state, we all know, is burning in the grip of cancer. It is nothing new. But Punjab is burning in the grip of cancer. And this was past of cancer, which was very bad. The present is really good. And the present is good, it's because of a strong teamwork. I'm a very strong believer of teamwork in cancer, and all specialty doctors, they contribute to the present successful scenic stories of cancer. And not only this, we are deeply, I'm deeply indebted to the surgeons, I'm deeply indebted to the radiotherapists, deeply indebted to intervention radiologists, just as Dr. Maheshwar was speaking here, the role of TACE and RFAs in hepatocellular carcinomas. We as chemotherapists are backseaters in the treatment of cancer because majority of the work is being done by surgeons because curative surgeries, they mean a lot in cancer. If you aim high, you can really achieve possible which looks to be impossible at the beginning. लेकिन हमें एक दूसरे के ऊपर विश्वास करके चलना पड़ता है और विश्वास करके ही चलेंगे तो सक्सेसफुल स्टोरी निकलेगी. If I say no, I have more work, I have a better placement in cancer treatment, I'm wrong. Everyone, every person, every doctor has its own supportive role. That's very, very important. Only then you can aim success. This is the cohort of patients which almost, I think, all of our physicians, ENT surgeons, gynecologists see in Delhi. रोज की ओपीडी 70 से लेकर 100 की होती है. उस 70-80 ओपीडी में से कैंसर को ढूंढना थोड़ा सा मुश्किल हो जाता है because we are in a rushy OPDs, heavy OPDs. Patients भी बहुत ज़्यादा they are very in this high tech world भी जल्दी तो कई बार कैंसर मिस हो जाता है. Routine OPDs में कैंसर मिस हो जाता है. So I don't want that the malignant cases should be missed in routine OPDs because the early you detect, the early the treatment, the better is the chance of cure. And the topic of today was actually how to detect cancer in routine rushy heavy OPDs. Like ECG, CBC is actually the ECG of human body, and peripheral blood smear is equivalent to echocardiography of human body. So like we have to be watchdogs, very strict watchdogs. Like which are those cancer patients which are sitting in my OPDs? Out of 100 OPDs, which are those cancer patients? So what actually matters is common misses, which we usually miss, and which I would be starting from an example. Anyone about an old male coming to you with chronic low backache, बहुत common सी ये patient हमारे पास आते हैं, old age with a chronic low backache. तो सिंपल सी बात है, सबसे पहले हम उनका think simple, think basics and think common. तो एक CBC, PVF and X-ray तो करवाते ही हैं. अगर CBC कराओ तो HB4, old age with a chronic backache with anemia. X-ray pelvis is available in almost every hospital of the government. What to talk of civil hospitals, it is even available in subsidiary health centers, the primary health centers, the civil hospitals. मैं ना बहुत ज़्यादा high-end investigations का fan नहीं हूँ, because मेरे को लगता है कि 99% diagnosis can be done from very very simple basic tests. अगर हम इस X-ray pelvis को देखें, तो हम सब एकदम उठ के बोलेंगे ये तो osteoblastic metastasis है. It's very simple. 100 रुपए का X-ray हो जाता है. तो osteoblastic metastasis, old age, chronic low backache, तो मेरे को कुछ नहीं करना यार, मैंने PSA नहीं कराना, और मैंने PSMA नहीं कराना, मैंने PET scan नहीं कराना, मैंने प्लीज कुछ नहीं कराना. मेरे को अगला सस्पिशन है, उसकी मैं PSA कराऊंगा, तो प्रोस्टेट कैंसर का डायग्नोस तभी के तभी मेरे सामने पड़ा. 100 रुपए मेरा डायग्नोस पड़ा, मैंने PM, PET scan, high end test. I'm not against PET scan. I'm sorry to say, I'm not against those PET scans. But मेरे को जहाँ सिंपल चीजों, सस्ती चीजों से अपना डायग्नोस बनता है, मैं उस भारत देश में रहता हूँ जहाँ पे पैसा वैसा नहीं है, तो मैं आराम से अपना डायग्नोस कर सकता हूँ. तो दिस इज वेरी इंपॉर्टेंट. ओल्ड एज, क्रॉनिक बैकएक, गेट एन एक्सरे डन. अगर ऑस्टियोब्लास्टिक मेट्स हैं तो एक PSA करा लो. PSA भी सब जगह मिलता है, हर लैब में PSA होता है. तो इट्स अ डायग्नोसिस ऑफ prostate cancer with secondaries. Yes, we can start with the treatment with a true cut biopsy of prostate. Simple. और क्योंकि एक्सरे में और तो स्टेज 4 एस्टैब्लिश हो चुकी है. अननेसेसरी MRI करा लो, ये करा लो, वो करा लो, ये करा लो. प्लीज, आई एम आउट ऑफ दैट हैसल. नेक्स्ट. अब वही ओल्ड एज फीमेल आते हैं. मैंने मेल की बात की है, फीमेल आते हैं हमारे पास ओल्ड एज. अब ओल्ड एज फीमेल अगर आते हैं, उनको बैकएक हो रही है, गेट ए CBC डन. अब CBC भी हर जगह है, उनको भी एनीमिया आ गया. गेट ए PVF डन. हमारे पैथोलॉजिस्ट इतने अच्छे हैं, बहुत पढ़े लिखे हैं. वी हैव लर्नड पैथोलॉजिस्ट अक्रॉस द ग्लोब, अक्रॉस पंजाब. आई थिंक in Bathinda even, I think there must be about 25 plus pathologists. I'm not very sure of the number. तो हर जगह ही हमारे पैथोलॉजिस्ट बैठे हैं और बहुत उम्दा काम करते हैं. और मैंने PVF अपने पैथोलॉजिस्ट को दी, मेरे को फोन आता है, सर वो तो रूले फॉर्मेशन है. रूले फॉर्मेशन, प्लीज कुछ नहीं सोचना. ओल्ड एज रूले फॉर्मेशन सीधा माइलोमा है, हाई इंडेक्स ऑफ माइलोमा. सिंपल सी बात है. कितने पैसे लगे? 100 रुपया लगा. तो कोई पैट नहीं, कोई कुछ नहीं, ये नहीं वो नहीं. प्लीज, देयर इज नथिंग ऑफ. हम जैसे हमारे डॉक्टर साहबान बैठे हुए अपनी अपनी चेयर पे एक, अगर हम सब डॉक्टर एक ही चेयर पे बैठ जाएं एक दूसरे के ऊपर, तो वो रूले बन गए. अब रेड ब्लड सेल्स अगर एक दूसरे के ऊपर बैठेंगे तो रूले बन जाती है. इट इज हाईली सस्पिशियस ऑफ मल्टीपल माइलोमा. सो इट्स अ रूले गैस इज माइलोमा, राइट? So oncotip is, if you find old age with anemia with रूले, it is myeloma. अब ESR एक टेस्ट होता है. It is running since centuries. I am very fond of this test. If ESR is more than 120, कुछ नहीं है भैया, it is a prostate, it's a myeloma. हमारी बुक्स लिखती हैं, सदियों से लिखती आ रही हैं, और ये फैक्ट है. मैंने जितने माइलोमा के पेशेंट देखे हैं, ट्रीट किए हैं, मेरे को नहीं समझ आती किसी का. मेरे को नहीं, मैंने I have hardly yet to find out a patient of myeloma with an ESR normal or 40 or 50. सबके 100 के ऊपर होते हैं. So oncotip is, think of myeloma in chronic low backaches, think of prostate cancer in low backaches in males, right? थिंक ऑफ माइलोमा, अगर आपको पंच आउट लीजन्स मिल जाती हैं एक्सियल स्कल में, एक्सियल स्कल भी आम चलता है, 100 रुपये का होता है, करा लो। ये नॉर्मल इलेक्ट्रोफोरेसिस है, ये भी नॉर्मल हो जाती है, हर लैब में होती है, हाई एंड हाई-फाई लैब नहीं चाहिए। अगर उसमें एम स्पाइक दिखती देन oncotype for multiple myeloma, bonolytic lesions, everything. So mission myeloma I have completed in suspect कर लेना multiple myeloma होगा। Okay. अब male है, female है with anemia and chronic fatigue. You see the PBF, and if you see HB4, but there is microcytic anemia. MCV is 10. Micro looks like nutritional. लेकिन ओल्ड एज में न्यूट्रिशनल माइक्रोसिटिक हाइपोक्रोमिक एनीमिया कुछ बात हजम नहीं होती है, ओल्ड एज हो गई, उसमें न्यूट्रिशनल ठीक है हो सकते हैं, मैं ये नहीं कहता नहीं हो सकते, बट प्लीज थिंक ऑफ कहीं ब्लड लॉस तो नहीं हो रहा, प्लीज लुक एट जीआई मैलिग्नेंसीज, स्टमक में ब्लड लॉस तो नहीं हो रहा, कोलॉन में तो नहीं हो रहा, ठीक है, बिकॉज स्मॉल ब्लड लॉस विल गिव राइज टू एनीमियाज। सो एनीमिया इन ओल्ड एज मस्ट नॉट बी डेल्ट कि ये न्यूट्रिशनल है, तो एक बार सोच लेना कि जीआई मैलिग्नेंसी तो नहीं है। अगेन वेरी इंपॉर्टेंट इन क्लिनिकल ब्रांचेस, अगर गम हाइपरप्लेजिया है तो एक्यूट माइलोइड ल्यूकीमिया का डायरेक्टली शक पड़ता है। ओके, नेक्स्ट कमिंग ऑन टू, आई थिंक वी शुड स्किप दिस। सो इफ यू फील लाइक मिशन एनीमिया इज माइलोमा आल्सो, मिशन एनीमिया कैन बी प्रोस्टेट कैंसर, कैन बी जीआई कैंसर्स, कैन बी focus, कहीं ना कहीं कुछ लाख 3 लाख, very common thing, it's a chronic myeloid leukemia. जरूर keep at the back of the mind, high TLC, big spleen, normal सा patient चलता फिरता आ रहा है with a normal platelet count, it is CML, कोई दिमाग लगाने की जरूरत नहीं, PPF कराओ और bone marrow and just proceed further. So I will skip all this and come directly to that. This was in the CBC, and word of caution is, next हमको टेबल unilaterality. Unilateral कोई भी चीज है सर, वो कैंसर है, 99%. You find a unilateral proptosis. It must be a tumor sitting behind the eye or an eye tumor. You find a unilateral tonsil enlargement. एक tonsil enlarge है, painless. I'm talking painless tonsil enlargement. It is highly suspicious of cancer, right? Unilateral neck nodes, especially the left neck nodes, left cervical जो area है ना, ये इसमें unilateral कुछ भी मिल जाए, तो समझ लेना कि ट्यूमर की high index of suspicion है. Unilateral deafness, acoustic neuroma. Unilateral epistaxis, अभी डॉक्टर साहब ने बोला angiofibroma of the nasopharynx, right? Then unilateral ptosis, unilateral meiosis. So meaning by unilateral कुछ भी हो जाए ना, तो वो कैंसर की शक में आ जाता है. It needs more interrogation. Issues of an endometrial cell. So ये छोटी-छोटी सी चीजें होती हैं, छोटे-छोटे tips and tricks हैं, जो कि अगर हम इनको अपना लें, रख लें अपने पास, I don't think we can miss cancer at any point. At the same time, at the same breath, I would say that I have written a book on cancer biology, choosing investigations wisely. उसमें सब कुछ लिख दिया मैंने. It's a very small book, but it's a very simple book. एक tip and trick मैंने लिखी हुई है, which doesn't cost anything. वो investigations की इतनी cost नहीं है. Then recurrent is very important. हमारा बच्चा स्कूल में पढ़ता है, बार फेल हो रहा है सेम सब्जेक्ट में, बार फेल हो रहा है, तो हमें होता है यार इसको ट्यूशन लगा दो, कुछ पढ़ा दो, कुछ अच्छा बन जाएगा, उसका सब्जेक्ट वीक है. ऐसे ही रिकरेंट कुछ भी मिल जाए, रिकरेंट एपिस्टेक्सिस, रिकरेंट हेमोप्सिस, रिकरेंट मलीना, रिकरेंट, जस्ट ट्राई टू फील कि हाँ ये हो सकता है, ओवेरियन कैंसर हो सकते हैं. This is the usual gynae OPD. The gynecologists are very fond of seeing obstetric cases daily. उसके बीच में एकदम कैंसर आ जाता है, ओवेरियन कैंसर. वो उसी से समझ आएगा अगर फैट 40 फर्टाइल फीमेल फ्लैचुलेंट बार फुलनेस ऑफ डाउन बोल रही है, तो ओवेरियन कैंसर की तरफ उसका शक जाना चाहिए. सो oncotype again, persistent bloating in females, fat 40 fertile flatulence, ovarian cancer should be suspected. So carrying a message is be vigilant, a little vigilant, and छोटे-छोटे टेस्ट जो आसान से सिंपल सस्ते टेस्ट के बहुत बड़े मतलब होते हैं, बहुत बड़े मतलब होते हैं. हर महंगी चीज़ अच्छी नहीं होती, हर महंगा इन्वेस्टिगेशन अच्छा नहीं होता. Thank you so much.
Hello. Thanks, sir, for a very informative, brief, and a precise lecture. I think the take home
pediatric patient or a leukemic pediatric patient. By subleukemic जब इसका इतिहास शुरू हुआ था तो ऐसे हुआ था कि normally क्या होता है कि जब bone marrow is packed with leukemic blasts, they should spill out in the peripheral blood. तो इनिशियल स्टेजेस में बोन मैरो में ब्लास्ट बनने शुरू होते हैं तो एकदम पेरिफेरल में नहीं आते. तो पेरिफेरल ब्लड फिल्म आपको पैथोलॉजिस्ट का फोन आएगा, सर ये तो नॉर्मल है, देयर जस्ट माइल्ड एनीमिया, माइल्ड थ्रोम्बोसाइटोपेनिया एंड न्यूट्रोफिल्स भी कम है, तो हमें लगेगा ठीक है, बट द मैरो इज पैक्ड विद ल्यूकेमिक सेल्स. व्हेनेवर यू फाइंड पैनसाइटोपेनिया और बाइसाइटोपेनिया in a pediatric population, please don't hesitate in doing an aspirate, because aspirate costs just I think 1200 or 1000 and it will give a diagnosis. Regarding mesenteric lymphadenitis, it's a very common entity because in pediatric patients there's a lot of worm infestations, appendicitis. Nodes, if they are more than 1 centimeter persistent, more than 1 centimeter solid, they are very high-grade lymphomas in children. If nodal size is increasing with a span of 2 months or 3 months, 1 centimeter से 2 हो गया, 2 से 3 हो गया, I think that should be biopsied, not to be kept under observation. Thank you, sir.
Sir, I am to Dr. Bajaj's question. Sir, most of the time what we see is that mesenteric lymph, even if the radiologists see the normal lymph nodes, they mention it as mesenteric lymph nodes. Good morning, everyone.
Am I audible? Yes. Just to add to Dr. Bajaj's question, good morning, sir. Mesenteric lymphadenopathy is often over-reported in many of the cases. So there is a very simple criteria. If the short axis, sometimes the lymph node size is 21 by 7 millimeter, 16 by 8 millimeter. So this 8 millimeter short axis diameter is more important than 21 millimeter long axis diameter, first of all. Secondly, lymph nodes become critical when they are found in clusters. If there is a cluster of 3 or more lymph nodes, then it points towards mesenteric lymphadenopathy. And third most important thing is maintenance of the corticomedullary differentiation. If there is an oncological thing, usually corticomedullary differentiation is lost. So always look for these 3 points in the report of a radiologist. This will help you in differentiating, and although cancer is quite rare, as Dr.
I'm not a very strong advocate of PET scan. PET scan has just got 2 indications. PET scan has got just 2 indications. One, in lymphomas for staging and response assessment. Any kind of lymphoma, Hodgkin, non-Hodgkin. 2, in cases of carcinoma of unknown primary. If you are not able to find a primary, PET will help you. It will not add too much to the things. In breast cancer, I don't think there is any role of PET scan.
Thank you, sir. Yeah, every investigation is not required routinely. Thanks for the next presentation, sir.
Thank you, sir, for your words of wisdom. Now I request the chairpersons to kindly felicitate Dr. Navdeep Singh. Dr. Navdeep Singh is author of a few books like My 6 Mothers and Cancer Biology, Choosing Investigations Wisely. Both the books are available on Amazon. Nextly, I request Dr. Surinder Garg to felicitate our esteemed chairpersons. Please give a huge round of applause for them. Thank you, sir, for your presence. Now my colleague Upneet will take over.
Thank you, Sukhnul. We now move on to our next insightful session titled Womb to Wisdom, Time to Upgrade Every Medical Specialty, Think Genetics. This thought-provoking topic reminds us that genetics is no longer confined to a single specialty, but is becoming integral to every branch of medicine, preventive care to precision therapy. To chair this session, we are honored to thank you, respected sir and ma'am. It is now my privilege. Thank you, respected sir and ma'am. It is now my privilege to introduce our speaker, of Health Sciences, Faridkot. She received the IC of Health Sciences, Faridkot. She received the ICMR DM thesis grant in 2022 and was awarded the ICMR Travel Fellowship for 2025 as a non-ICMR scientist. Her research contributions have widely recognized. She secured the second position in DM thesis research category at ResearchCon 2024 organized by IAP Research in Child Health Society. She also won third prize for a poster presentation at the 3rd National Symposium for Genetic Disorders held at Army Hospital, New Delhi. Dr. Gupta has an impressive academic record with 31 publications, 1 book chapter and 1 patent to her credit. Ma'am, we are honored by your presence and look forward for your valuable insights. Kindly take the stage, ma'am.
Medical genetics from PJ Chandigarh. So the topic I have chosen today is I will be showing a few case scenarios highlighting the importance of a geneticist or a genetic testing ranging in all the age groups from antenatal period to old age, that is from womb to wisdom. So the overview of my talk includes that why do we need a genetic testing in present scenario? Second is relevance across various specialities, and it will be a case scenario based discussion, and followed by common indications of genetic consultation in a genetic clinic. So we all know that genetics is highly into our routine practice. So how does it add into our daily practice or clinical care? It helps in an early diagnosis and accurate care, especially in unexplained clinical conditions. Second is personalized management and treatment decisions. Third is identifying various at-risk family members. And fourth is reducing unnecessary investigations and healthcare costs. followed by empowering the patients through informed decisions. So I'll be explaining each one of them using different cases. So coming to case scenarios. So this is a family who came to me at 2 months of pregnancy. They came to me with an abnormal HPLC report. HPLC, as we all know, is used to look for hemoglobinopathies. They can detect heterozygous states, which is carrier state, or in homozygous, the disease status. And nowadays, HPLC is recommended in all the pregnancies. Why? Because in 15 individuals, one person is known to be a carrier of beta thalassemia. So in earlier times it was an optional test, but nowadays it's said that all pregnant females should get an HPLC done, due to which this lady got an HPLC and she got an elevated HbA2. So with that report they came. This was their third pregnancy. First child had died at term gestation, at birth only, due to unknown cause. Second was a female child around 2 years of age, and now 2 months of next pregnancy. So this was a report for HPLC. As we can see that HbA2 level is highly elevated to the tune of 29.5%. Depending upon different levels of HbA2, we detect different types of hemoglobinopathies. And this HbA2 level was suggestive that she had an HbE trait, meaning she was a carrier for thalassemia HbE. And if this thing is found in one partner, we have to look for the other partner also, that is the partner a carrier. So the husband's HPLC also showed that he was a carrier, and it was a beta thalassemia carrier due to elevated HbA2. Now both partners are carrier for 2 different mutations, which means that their coming baby, the next baby, is at risk of having E beta thalassemia, which is a morbid disease, and it is transfusion dependent and poor long-term prognosis. So how much is the risk? For autosomal recessive disorder, there was 25% risk. So in these cases, we have to tell the family about the expected prognosis or the chances of fetus having the disease, and we offer invasive testing during the pregnancy. So mutation testing of parents or the couple also confirmed the same trait, followed by prenatal testing was offered for the ongoing pregnancy, so that they can make an informed decision. If the fetus is affected with this hemoglobinopathy, they can decide they have to continue or to terminate. Now what about the other child who came along with them, who was 2 years old? On examination, she also had a pallor, she also had splenomegaly, and an HPLC was done for her, which confirmed that she was having E beta thalassemia. So this child was also started on regular follow-up, hydroxyurea and supportive care. Plus, in the ongoing pregnancy, prenatal testing was offered. So in this, the previous pregnancy itself could have helped in the informed decision for the second child. Now coming to an interesting case, this family had repeated infantile deaths, meaning within 1 year the child will come and die due to some cause. So they came to me for a workup regarding this. So all the 3, they had died before 1 year of age. On taking the history, I could find that all the babies had a term delivery, they were appropriate for gestational age, they had good birth weight, they were apparently well. However, they had some intestinal malformation, which was usually diagnosed at 3 to 4 months of age. They were operated upon, but they could not survive till 1 year of age. So all the 3 babies, they had the same history. There were no samples, no photographs of the children, there were no records, nothing, no documents. So upfront with this history, it appeared to me that it was some recurrent gastrointestinal anomaly or Hirschsprung disease, which was leading to death of the kids. However, no details were available. Based on this history, a genetic evaluation of both the partners, like the couple, was done, And interestingly, it came out to be that both the partners were carrier for a variant in CFTR gene, which means that children were repeatedly having cystic fibrosis, and they were getting meconium ileus, which was getting operated. However, due to other complications, they were not able to survive. So in this family, early and accurate diagnosis could have helped in informed reproductive decisions in all the three babies. At least after the birth of second child who had the same illness, a genetic workup should have been done. Plus, had they known that it was a CF, this child could have been managed better and might have been saved. This was another case. This was a 7-year-old girl who had ectopia lentis. She had myopia. So any person, any child, any adult having ectopia lentis, we always think of Marfan syndrome. That is very common, we all know. She had Marfanoid habitus, but she had a short stature. Marfans usually have a tall stature. So this girl had a short stature. She had dark skin, sparse hair. Additionally, she had some dysmorphism with blue sclera, deep set eyes, high arched palate, etc. Plus skeletal deformities. Suspecting a Marfan's, an echo was also done, which was normal. Plus Marfan syndrome systemic score was also borderline. So any child with Marfanoid habitus, short stature, and some intellectual disabilities, skeletal malformations, it means there is some metabolic cause. And she was worked up for a metabolic disorder, and there was elevated homocysteine, elevated methionine, but there was a normal B12. This test was confirmatory that she had homocystinuria, which is not very uncommon in pediatric age group. Plus there was a history of cousin marriages in her parent, which was another pointer for having this homocystinuria. Plus genetic analysis confirmed that it was a case of homocystinuria. Now, how could we change the management in this child? She was started on treatment of homocystinuria, which is some vitamins and supplements. And she was also kept on regular surveillance for the risks involved in these babies. Plus prenatal testing for other pregnancies was also advised. So, here personalized management and treatment decisions could be given to the family, and the child had improvement, plus she could be saved from future complications of the same disease. Also, we could tell them that there are chances of stroke or hypercoagulability, so this child has to be taken care about that. This was another case, a 40-year-old male. He had severe depressive illness. He was on electroconvulsive therapy. There was poor response, suicidal attempts, and seizures. Nose was bulbous. There were wrinkles on the face. There were some hyperpigmented spots on his skin, if they are visible on the chest. And there were some hypopigmented spots as well. So this is of demoralizations, and they may benefit from psychological interventions aimed to decrease internalizing problems, introversions, etc. Secondly, these patients have cardiac anomalies which keep on going silent throughout the life, like pulmonary stenosis or hypertrophic cardiomyopathy leading to sudden deaths. There should be careful selection of drugs in such patients. For example, we have to avoid the drugs with QT prolongation, citalopram. 60-year-old female who was diagnosed with atrial fibrillation and dilated cardiomyopathy in 2022. For this, she was medically managed. MI was ruled out clinically. Her cardiac MRI showed, again, no evidence of family history of cardiac diseases. For example, in this pedigree, the one with the arrow, the one with the arrow is the person who consulted. She had DCMP. She had 4 other siblings. In those 4 siblings, the last one, the male, he had coronary artery disease at 40 years of age. She was 60 years of age. Her father had heart failure, father's brother, father's sister had heart failure and sudden death, and her grandfather also had heart failure and sudden death. As her workup was almost negative, she was presumed to be a COVID-induced viral dilated cardiomyopathy and was being managed. But in view of significant family history, genetics was offered and she had a genetic mutation leading to this dilated cardiomyopathy. So after her diagnosis of genetic cardiomyopathy, her other members we could screen, plus we knew her cause, that she had DCMP due to TK. Like her daughter, she was asymptomatic, around 30 years old, but she also carried the variant. Her younger brother, who was 10 years younger to her, he also had this variant. So in this family, the other one brother who had coronary artery disease, no evidence of DCMP, he did not harbor the mutation. So in this family, we could offer a better and confident care to this female who was 60 years old. Her prognosis could be ascertained that it was a fair prognosis disease. And for her family members, like her brother and her daughter, screening was started, plus some cardiac remodeling agents were advised after the age of 40 years, at which age this DCMP usually sets in. So here we could identify other at-risk family members and improve their future and their life. Plus, we could reduce her unnecessary investigations like CT angio and healthcare costs and give her a better management. So, just this slide is a revision that when to think of a genetic cause, like any blindness, cardiac disease, recurrent pregnancy losses, abnormal face, short stature skeletal deformities, cancer in the families, any abnormal ultrasound do not touch because it is commonly, we know that genetics is used in this domain, plus unexplained neuromuscular illnesses, etc. So, to conclude, genetic testing is no longer domain of every clinician should suspect, do appropriate workup to enhance the diagnostic accuracy, improve the outcome and empower the patients through use of genetics. And with increasing accessibility, it is becoming indispensable part of everyday practice. Thank you.
Enlightening lecture. I just want to ask, like, as a setup in Bathinda, most of the clinicians which are working and having heavy OPDs, like, what do you think, like, can be the starting point for suspecting the genetic cause in many of the cases?
And vitamin D supplementation, which could be life-threatening to them. Usually developmental delay kids, they keep on getting these supplements and all, but in these kids, due to primary hypercalcemic state, they are not to be given. So that way management also changes with these kids. And definitely the family history thing. Yes, sir.
One more thing.
How much stress is needed? Can we start the treatment
for a cardiac evaluation or for other systemic searches? So yes, labeled as malnutrition, failure to thrive. But if we are looking at some atypicality, we should think genetic. We should do the literature search. We should, put the handles in the Google at least that okay, low set here, kya ho sakta hai? Let me check kya ho sakta hai. We can do it on a simple phone.
I think Dr. Shiva is a very big asset to Bathinda, because there are very few people, very few doctors in whole Punjab. I have not actually, no one in Ludhiana, Amritsar, Jalandhar. She's going to be very big asset to the public, to everyone. And with her introduction in Bathinda, she's going to open a Pandora box for many diseases. Because when diseases get diagnosed at cellular level, then it's going to open a very big Pandora box. Really good, man. Thanks.
Sir, thank you for your encouraging words.
Hello. Once we use drugs for patients, maybe can the genetic testing help us?
Panels available. For example, any cardiac patient you are having, or patient's patient, he's, you need to know that which drug he will respond to, how much dose he will respond to. There are panels that we can get done and tailor their medications accordingly. Second thing, this is for a normal patient. Second thing that I have shown is for syndromic patients. It's very important because sudden death if happens now, everyone is frightened that why this patient has gone. We should know which syndrome it is, what he was suffering from. That is why he had this complications or so. For example, hematemesis. EDS, Ehlers-Danlos syndrome, they will have hematemesis anyways, but they will not look like Ehlers-Danlos, not very typically dysmorphic. So in such cases, we should think of that, isko kaise ye ho gaya? There is no risk factor. We should think it could be some connective tissue disorder and get it proven for a long-term care.
Like most of the, when I was...
So actually, this is because one is, networking and documentation. Those people, they collect the data. Okay.
In early 1900s, there were syndromes which were being diagnosed for the first time. But there was no genetic testing. There was no genetics at all at that time.
Yes.
But even in today's time, India is not diagnosing anything new.
I mean, it is all due to logistics and money thing and all. I would like to tell you that first NG machine was made by an Indian, but in, outside India. So that way Indians are way ahead. But as, I'm also struggling to tell people, okay, we need genetics. That way, this is a new thing in India. It has just started like 5 years back in PJ, they started a DM course. That is why there are less number of people. Second thing is that to label a syndrome, we need very high-fi functional studies that are happening only in one institute in India and rest in abroad. So that is why they take their names that, okay, this is Noonan and all. So otherwise, there are a lot of patients and research as well as, of course, they can diagnose.
I have a very simple question. हमारे पास रूटीन प्रैक्टिस में ना पेशेंट्स आते हैं, कहते हैं कि हमें जानना है कि हमें कोई कैंसर तो नहीं हो गया है, क्योंकि हम मालवा रीजन में रहते हैं। कहते हैं कि हमें कोई भी पैनल करवा दो, कोई टेस्ट करवा दो। अब जो मार्केट में इतने सारे पैनल्स आ गए हैं, क्या हमें वो पैनल्स करवाने चाहिए? क्या हमें उन्हें एडवाइस करनी चाहिए? क्या हमें ऐसा करना चाहिए या नहीं?
ऐसे पेशेंट्स के लिए पैनल्स तो सिंपल है, ब्लड टेस्ट लिया, पैसे दिए, हो गया। द इम्पॉर्टेंट थिंग इज समझेंगे कैसे कि उसको क्या होने वाला है। उसके लिए फिर आपको थोड़ा उनको काउंसलिंग का जरूरत रहेगा, उनको बताना पड़ेगा। और मैम ये नहीं होना चाहिए कि उसमें आ गया कि आपको ब्राका म्यूटेशन है, फिर वो पेशेंट ब्राका से तो नहीं कुछ हो, वैसे ही डिप्रेशन में चला जाए कि मुझे ब्रेस्ट कैंसर हो जाएगा, है ना? For scientifically, for that we have a pre-test counseling and a post-test counseling. Pre-test में हम उन्हें बताते हैं कि आपको ये रिजल्ट्स आ सकते हैं, मतलब उसका एक पूरा प्रॉपर फॉर्मेट और वे है कि आपको ये सब हमें पता चल सकता है अगर आप चाहो तो। लेकिन इसका मतलब ये नहीं है कि आपको कैंसर हो गया है, हम आपको सर्वेलेंस पे रखेंगे। मतलब उनको ये अच्छे से एक्सप्लेन होना चाहिए ना, ऐसा नहीं है कि फिर बाद में म्यूटेशन आ गया और फिर वो ऐसे ही।
ऐसे काउंसलिंग यहाँ बठिंडा में कहाँ अवेलेबल है, प्लीज उसके लिए भी बताइए हमें।
I mean, geneticists only do, ma'am. I tell them like मैं उसी पार्ट में करती हूँ।
Okay, thank you so much. Thank you.
Can do that.
Just a last question. अगर डाउन सिंड्रोम 1 in 200 होता, तो मैंने अपनी जिंदगी में बहुत सारे डाउन सिंड्रोम के पेशेंट्स देखे होते और पब्लिक में भी दिखते हैं लोग, बट इतना कॉमन नहीं है ये। और ये जो डाटा हम बाहर से लेके वही डाटा हम यहाँ पे कॉन्फ्रेंसेस में डिस्कस करते हैं ना और करते हैं, तो एक नोशन से सेट हो जाता है। तो आई थिंक दिस डाटा इन इंडियन सिनेरियो इज वेरी डिफरेंट। आई थिंक मुझे नहीं लगता कि 1 in 200 डाउन सिंड्रोम होते हैं। इज इट, डू यू एग्री विद मी?
जैसे बुक्स में लिखा है 1 in 750 आपका डाउन सिंड्रोम आपको मिलेगा, 1 in 750 के आसपास। ठीक है, हो सकता है कुछ वेस्टर्न लिटरेचर से भी हो, लेकिन ये भी जानना जरूरी है सर कि सारे डाउन सिंड्रोम बैड नहीं होते। सम ऑफ देम गो टू स्कूल, सम ऑफ देम रिमेन नॉर्मल, डोंट इवन नो कि इनको डाउन सिंड्रोम है। आई हैव सम पेशेंट्स लाइक शी वाज एन एडोलेसेंट, शी गॉट दिस एटलेंटोएक्सिल इंस्टेबिलिटी फॉर विच जो आप HPLC का कह रहे हैं वो हमारा इंडियन नॉर्थ इंडिया का डाटा है, PGI की स्टडी है। नॉर्थ इंडिया में 1 in 15 इज द कैरियर फ्रीक्वेंसी। सो कैरियर तो हो सकता है कम।
Thank you for the wonderful session, Dr. Shifali. It was really, you deepened our knowledge on the subject. Thank you so much.
Thank you, ma'am. Thank you.
Thank you, ma'am, for that enlightening and thought-provoking presentation. Now, I would kindly felicitate our speaker, Dr. Shifali Gupta, as a token of appreciation and gratitude.
He is recipient of many prestigious national and international awards. Sir, please join us on the stage. We are truly privileged to have Dr. Vaibhav Saini, MBBS, MS, and DNB in otorhinolaryngology. He is additional professor and head of department at ENT, AIIMS, Bathinda. Dr. Saini has previously worked as assistant professor at GMCH Chandigarh and Lady Hardinge Medical College, New Delhi, before resuming his current leadership role at AIIMS Bathinda. Sir will be enlightening us on the topic parathyroid surgery, a tiny gland with major impact. May I request respected sir to kindly come upon the stage.
Good morning, all the dignitaries on the dais and off the dais. And I'm really thankful to Dr. Vikas Chavda for giving me this opportunity. When he gave me this opportunity two months back, so I thought, what could be the topic of my talk, which is apart from the hardcore ENT, because I was expecting not the audience. So a topic which is usually comes across. I think the patient of parathyroid or hyperparathyroidism usually touches every specialty. So more or less, we all see such patients. Very easy surgery with gratifying and immediate results and opens up a different dimensions in our day-to-day practice. This condition is often underdiagnosed. Symptoms are vague, can mimic psychiatric symptoms or aging problems. Early detection prevents complications. So what is parathyroid glands or what is parathyroid? Parathyroid glands are small glands located in the neck behind the thyroid. These are very, very small glands, yellow, brown or red bodies, about 6 centimeter long, 3 to 4 mm. human body generally have 4 parathyroid glands bearing atopic glands. If some atopics are there, so they can be many, otherwise there are 4 glands. There will be increased calcium absorption. There will be increased calcium absorption from the kidneys, as we call stone, or increased calcium uptake in the intestine that can cause gallstones and all things. So calcium metabolism is very important for bone mineralization, blood coagulation, neuromuscular transmission, neurotransmitter release, contraction of muscles, cell membrane and permeability, and secretion of glands. So if PTH is deranged and vis-a-vis then calcium is deranged, so much things are affected in their body. This is a basic slide of basic slide of types of hyperparathyroidism. Primary hyperparathyroidism, where the parathyroid gland is secreting parathyroid, and secondary hyperparathyroidism, it occurs in patients with chronic renal failure and vitamin D deficiency, and tertiary hyperparathyroidism in case of renal failure. Most importantly, why this topic is important and interesting, that the patient has very, very vague symptoms. It has ranging from abdominal pain, fatigue, multiple joint pains, pelvic pain, and low mood. So generally, this patient of hyperparathyroidism can land up to each and every specialty. Symptoms might range from depression, anxiety, insomnia, irritability, to osteopenia, osteoporosis, bone pain, joint pain, muscle weakness, heart palpitation, GERD, abdominal discomfort. In severe cases, it has pancreatitis and low vitamin D, kidney stones, and excessive urination. So there is no other disease that is so easy to cure, that has such a huge impact on personal overall health and their quality of life. So these are causes. We'll be focusing mainly on primary hyperparathyroidism or a parathyroid adenoma. So single parathyroid adenoma is usually most common type of primary hyperparathyroidism. 80 to 85% of cases are usually single adenomas, and rest 15 to 20% are multiglandular disease. Very rare parathyroid carcinoma and hereditary in men and other syndromes. So solitary parathyroid adenoma, here we can see. Can I have a pointer? I don't have a pointer. Can you give me a pointer? Okay. This is adenoma. This is a retracted thyroid gland. So this is solitary parathyroid adenoma. Here we could see. So not so uncommon an endocrine disorder. It is more prevalent with routine biochemical screening. Usually initial days when we don't used to have access of routine calcium examination, routine calcium, serum calcium, this disease was often underdiagnosed. With routine biochemical screening, a simple serum calcium usually diagnoses a lot more hyperparathyroidism than it used to be earlier. More commoner in female, annual incidence is 20 cases per 10 per 1 lakh. Prevalence is 0.5 to 1%. The classical description in the books of the MBBS, what you used to read, painful bones, renal stone, abdominal groans, and psychic moans are rare nowadays. Most patients nowadays present with subtle symptoms like muscle weakness, joint pain, polyuria, mild depression. Diagnosis is usually made when there is a hypercalcemia associated with raised PTH levels. Surgery is a treatment of choice, and preoperative localization is the key in this disease. Slowly we come on to the each and every topic, each and every term on this slide. So it is basically a study we conducted at AIMS consisting of 65 patients, and in our study mostly patients were males as compared to the normal norms where the patients mostly were females. So now here it's the interesting part. Most of the patients came from endocrinology, but 9 patients from nephrology, 8 patients from general medicine, 6 patients from orthopedics, 2 patients directly landed up to us with a neck mass, 2 patients were having pancreatitis and they were admitted in general surgery ward, and 1 patient came from gynecology. So you see that this hyperparathyroidism patient will not directly go to an ENT. The process cystica, this was one 19-year-old female which presented to us. This has typical textbook appearance of salt and pepper skull, lytic lesions in the distal part of the bones, and you can see the bones have become typically this typically bone has gone from inside, it's totally weakened. Bony resorptions and resorptions of pharyngeal part. This is the ulnar part of the finger, and they will see typical resorption of the bones. Just showing lytic lesion, or it is called 1500 picogram per ml. 1500 picogram per ml. Imaging studies for localization. Ultrasonography in the neck was done on all 61 patients, and system scan as a gold standard is done for 59 patients. Two patients were bedridden, so they could not go for a system scan. Now, coming to USG, it is a first-line investigation. It is inexpensive, widely available. It has no radiation exposure. Around 90% sensitivity and specificity. Concomitant evaluation of thyroid pathology is also important. Sometimes when you go and operate a parathyroid adenoma, generally thyroid is also nodular, so you have to be very careful about that. But only limitation of it is a user-dependent interpretation, and ectopic glands or deep cerulean might be missing. Now, systemic scan, it is a scintigraphy. It is technetium-99 systemic scintigraphy. It is a gold standard. Systemic is lipophilic cation. It accumulates in the mitochondria. It has ease of interpretation, and assessment of ectopic glands also can be done. Ruda et al. Has pooled sensitivity of 80%. USG plus systemic B, which you usually follow, we do both investigation in our patients as 95% of the sensitivity, but it has radiation exposure. Other high-end investigations, now we have started doing, because of the installation of PET scan at our center, we have started doing PET and 4D CT in cases of unequivocal results. For example, in the cases where USG and system we don't coincide with each other, we go for a higher investigation. Otherwise, these USG and system are more than sufficient. Other investigations are selective venous sampling and parathyroid ectopography. Most important now, our protocol for localization is we go for system AV and ultrasound. If they indicate in the same thing that left inferior or right inferior parathyroid gland is involved, we go for a focused thyroid surgery. If they show a discordant result, then we consider going for a higher investigation like 4D. Initially, you could see that incision was quite big, around 6 centimeter. Then later on, incision around 4 centimeter. We will later on I'll see that incision can become more smaller and smaller. So typical steps of surgery: we identify a thyroid lobe, we retract the thyroid lobe, identify the recurrent laryngeal nerve. We retract the thyroid lobe, identify the recurrent laryngeal nerve, and this is the parathyroid adenoma, and we remove it. Gland. Similarly, this is osteofibrosis cystica, retracted thyroid lobe, laryngeal nerve. This is a giant parathyroid adenoma, very rarely seen. Palpable parathyroid gland is very rare to be seen. This is around 4 centimeter gland. This was a patient, 35-year-old female, almost bedridden, and we had an opportunity to have a CT scan in this patient. Usually, we don't do a CT. So this is thyroid gland, this is trachea, and this is a huge parathyroid adenoma, around 4 centimeter size. Surgery becomes more and more easier the kind of the gland size of the gland increases. So here you could see the 4 centimeter. Now coming on to minimal invasive approach that we are following right now. So now when we gained more and more experience in this surgery, now we started planning this. We have marked the thyroid gland, and along with the USG, we know the right inferior parathyroid gland is involved. Here, right inferior parathyroid gland is involved. So what we do is, we just give a small incision where we think that there is going to be a gland, and you can see the incision is just 2 centimeter. Now we do a retraction, identify and detect the thyroid node. Rest of the symptoms are the same. Here, identification of the parathyroid. It's a tricky surgery in this is a small. You can use endoscope in such cases. Here we have used endoscope. This is an endoscopic picture. This is the thyroid bed, and this is the parathyroid gland. We are separating parathyroid gland from the thyroid bed, and it will be easily removable. This is a bilateral parathyroid gland removal. One thing which is very important, which has, I think, in all of India, we are lucky to have indocyanine green and a camera associated with indocyanine green. So what is indocyanine green? This is a lipophilic protein which accumulates in the blood vessels, and it accumulates in the parathyroid gland. It makes identification of the parathyroid gland during surgery is very, very, very easy. So I will not go into the details because we are running short of the time. This indocyanine green commercially in the injection form, we give just prior to the incision, and after 5 to 10 minutes, when we see during, you could see the parathyroid gland emits like a bulb. So it makes the surgeon's work very easy. And easily you could see the parathyroid is anything like green bulb, and you can easily remove this. This is a video which is showing. Here you could see. This is the parathyroid gland. So we are kind of lucky that the company, when they supplied to us, after that there is some system malfunction, and right now this system is available at AIIMS Bathinda. It is not because it is only available at AIIMS Bathinda. Company has backend some failure. Right now it is not available anywhere else, which is soon going to be available. It is a very, very good thing. Another surgery in which the parathyroid gland is typically elicited. Intraoperative, we send a frozen section and a turbo PTH. Turbo PTH is basically PTH which comes within 15-20 minutes. So here you could see before incision, the patient was having 1354, 1400 PTH, and immediately after removal 5 minutes, the PTH went down to 148. So that is why the 10 minute of half-life of PTH was very important. This is we can have intraoperative success of surgery. Stress monitoring of the calcium and PTH post-op period are typical discharge card like this. Preoperative serum calcium is this, serum phosphorus is this, PTH is this, and PTH fault post-op. I know we are running short on time. This is use of turbopatent ICG has made our life very easy. It is typical case presentation of a female female with presented with 16 weeks of pregnancy with double adenomas. It was a difficult multidisciplinary team was there, having endocrinologist, obstetrician and anesthesia. And we were able to remove, this is the both bilateral parathyroid. This one is the larger, this one is smaller. This is a histopath report of that patient. Patient was monitored by gynae team and endocrine team. Now the patient, it is from 3rd of the September, the patient was 31 weeks, 31 week in gestation. Recently the patient came to my OPD, he has delivered a beautiful baby boy and doing fine. So my journey so far is pre-operative localization the key. Endocrinology support is the basic minimum because most of the patients with high PTH develop hungry bone syndrome and they go into hypocalcemia immediate post-op. Only a good endocrinologist team can manage in post-op. Case selection is very important. Complications can occur.
Tests like CTs, MRIs and all that went to all the surgeons, gastroenterologists, everyone. Repeatedly, she had done all the routine investigations also. The calcium was slightly on high side and creatinine was also the borderline. So nobody was taking care of the calcium and all that. And it was basically because of hypercalcemia, and once we did the systemic scan and all that ultrasound, it was basically because of parathyroid adenoma. So it's very, very important. Once the patient has chronic pain abdomen, please check calcium level also at the same time. Chronic pain abdomen, please check calcium level also at the same time. Very important. Now there is, you're talking about intrathyroid PTH level. This is very, very important. Once you operate for adenoma, and at the same time, once once you check IPTH, if it is not coming down, you might have operated a wrong adenoma, or it might be double parathyroid adenoma. Yes. It is very important. And about it might be double parathyroid adenoma. Yes. It is very important. And about hungry bone syndrome. Hungry bone syndrome. This is a serious issue. You have to take care of that. And at that time, you might require our help also.
Yes, sir, definitely. We have Dr. Shivani with us. So there's a general saying in our department, देखो भाई मैं तो कारपेंटर हूँ, मैं ऑपरेट कर दूंगा, उसके बाद जो कैल्शियम लेवल है वो डॉक्टर शिवानी आके देखेंगे. So that is the kind of a thing कि generally what we have seen, the patient who have very high PTS pre-operatively, they tend to go more in hungry bone syndrome post-operatively. Generally when we operate around 300 to 400 PTS, they don't move in hungry bone syndrome. But if the patient is having 1500 or 1600 PTS, they definitely go in hungry bone syndrome, and it's quite a complication, I think I would not say complication, sequelae, which is usually managed in 3 to 4 days. But yeah, endocrine support is a must.
हंगरी बोन सिंड्रोम में क्या होता है कि जैसे हाइपरपैराथायराइडिज्म की वजह से पीटीएच लेवल अगर ज्यादा होगा तो क्योंकि ऑस्टियोपोरोसिस होगा, कैल्शियम सारी बोन से निकल जाएगा. जैसे हम ट्रीट करते हैं, पीटीएच लेवल डाउन होगा तो सारा बोन्स वापस वो हंगरी होती है क्योंकि सारा कैल्शियम निकल जाता है. जब पीटीएच लेवल कम होगा तो ऑस्टियोब्लास्ट स्टार्ट्स वर्किंग, ऑस्टियोक्लास्ट कम हो जाते हैं तो सारा कैल्शियम बोन्स ले जाती है. दे आर हंगरी, सारा कैल्शियम निकल गया तो उनको वो एकदम कैल्शियम ले जाते हैं. सीवियर हाइपोकैल्सीमिया हो सकता है, टेटनी हो सकती है. तो वी शुड मॉनिटर देयर कैल्शियम एंड दे माइट रिक्वायर आईवी कैल्शियम आल्सो, एंड इट might continue for 3-4 days, 5 days. So it's very, very important. Tetany का देखना पड़ता है. Yes, and the common symptoms of low calcium is tingling, numbness in fingers, tips, all these symptoms. So hungry bone syndrome is an important thing to take care of. Yes. Any questions from the audience, please? Any feedback? Any questions from the audience? My co-chairperson. Thank you so much. Thank you. Thank you so much.
Thank you, sir, for sharing your thoughts and profound wisdom. We truly appreciate the insight you have shared with us today. Now I request respected chairpersons to kindly felicitate Dr. Vaibhav Saini. After intense discussions on guidelines, protocols, and evidence-based debates, now it's time for a short. We'll all gather here after the
कोई नहीं हो गया उनका खत्म ना.
बंद कर दें. हाँ तो कर दूंगा. यही क्यों नहीं उस पैसे ले हो वीआईपी ने. अच्छा वो वीआईपी है नकली सारा सुधार लगा सारे पिक्चर कर दी बटन दबो ਉਹ ਮੂਲੀਆਂ ਸਿੱਟਾ ਬਟਨ ਮੈਂ ਕਢਾਇਆ ਲੈ ਮੁਰਗਾ ਮੂਲੀ ਸਿੱਟਾ ਟੇਢੀ ਹੋਇਆ ਹੈ ਚਿੱਤਲ ਵੀ ਜਾਂਦੀਆਂ
ਅੱਛਾ ਦੀਵਾਰ ਦੇ ਨਾਲ ਅਗਰ ਕੋਈ ਨਹੀਂ ਜਾਣੀਆਂ
ਅੱਛਾ ਇਹ ਨਹੀਂ ਆਉਣਾ ਨਾ ਉੱਪਰ ਲੱਗ ਜਾਣਾ ਭਾਈ ਆਪ ਕੋਈ ਹੋ ਜਾਂਦੀ ਹੈ ਸਪਸ਼ਟ ਨਹੀਂ ਭਾਈ ਫੋਟੋਆਂ ਕਰਤੀਆਂ ਟੈਨਸ਼ਨ ਨਾ ਲੈ ਕੁੜੀ ਨੂੰ ਕਿਹਾ ਪਿੱਛੇ ਚਾਉਂਦੀ ਸੀ ਵਿੱਚ ਲੈਣਾ ਜੀ ਇਹ ਫਰੇਮ ਦੇ ਉਹ ਥਾਲੀ ਤੋਂ ਖਾਲੀ ਸੀ ਦਵਾਈ ਜੋ ਬਹੁਤ ਵਧੀਆ ਹੋਈ ਵਕਤ ਜਿਵੇਂ ਤੂੰ ਕਹਿੰਦੀ ਸੀ ਉਵੇਂ ਕੀਤੀ ਹੈਲੋ ਕੋਈ ਆਈ ਜੀ
ਤੇ YouTube ਤੇ ਲਾਈਵ ਕਰਦੇ ਹੋਵੇ ਇਦਾਂ ਹੀ
ਹਾਂਜੀ
ਤੇ ਲਾਈਵ YouTube ਤੇ ਕਰ ਰਹੇ ਕਰਦੇ
ਇਹ ਸ਼ਾਇਦ ਚੈਨਲ ਤੇ ਹੀ ਆ ਰਹੇ ਆ ਸਾਰਿਆਂ ਨੂੰ ਦਿੱਤਾ ਹੋਇਆ ਲਿੰਕ ਵਗੈਰਾ ਇਹ ਇਹਨਾਂ ਦਾ ਪਰਸਨਲ ਦੇਖ ਲਓ ਵੀ ਪੂਰਾ ਕਰਕੇ ਕਿੱਥੇ ਹੈ ਹਾਂ ਕਿਹੜੇ ਮੇਨ ਗੈਸਟ ਸਾਰੇ ਕਿਸੇ ਨੇ ਕਰਾਇਆ ਕਿਸੇ ਨੇ ਨਹੀਂ ਕਰਾਇਆ ਕਿਸੇ ਨੇ ਕੱਟ ਲਿਆ ਠੀਕ ਹੈ ਮੂਰ ਲੈਣੇ ਕੋਲੋਂ ਕੱਟ ਲਿੱਤਾ ਨਾਵਲ ਬਦਲ
ਕਿੱਥੇ ਲਾਈਵ ਲਾਈਵ ਕੀ ਦਿਹਾੜੀ ਲੈਂਦੇ ਆ
ਇਹ ਉਹ ਬਾਕੀ ਵੀਡੀਓ ਨਹੀਂ ਪਤਾ ਜੀ
ਨਹੀਂ ਆਈਡੀਆ ਵਿਆਹ ਸ਼ਾਦੀ ਦੀ ਲਾਉਂਦੇ ਹੋਣੇ ਆ ਤੇ ਚਲੋ
ਅੱਛਾ ਹਾਂ ਉਹ ਤੇ ਜੇ ਪਰਸਨਲ ਆਪਦਾ ਕੈਮਰਾ ਫਿਰ 4500 ਰੁਪਏ ਦਿਹਾੜੀ ਪੈਂਦੀ
ਲੈ ਕੇ ਜਾਂਦਾ ਯਾਰ 5,000 ਲੈਂਦੇ ਪਹਿਲਾਂ ਮਾਰਕ 3 ਕੈਮਰੇ ਤੇ 6,000 ਲੈਂਦਾ ਹੁੰਦਾ ਸੀ ਕੈਨਨ ਦਾ ਉਦੋਂ ਮੇਰੇ ਕੋਲ ਆਪਦਾ ਹੁੰਦਾ ਮੈਂ ਵੇਚ
ਹੁਣ ਕਿਹੜਾ ਪਾਇਆ
ਹੁਣ ਹਾਲੇ ਵੇਚਦਾ ਸੀਗਾ ਦੁਬਾਰਾ ਲੈਣਾ ਜੀ
ਕਿਹੜਾ ਲੈਣਾ
ਸੋਨੀ ਦੇ ਲਵਾਂਗੇ
ਸੋਨੀ M4
5 ਲਵਾਂਗੇ ਜੀ
ਇਹ ਸਟੈਮ ਕਰਦੇ ਨੇ ਕੈਨੇਡਾ ਵਗੈਰਾ ਕਰਦੇ ਆ ਫਿਰ ਉਹਦੇ ਲਈ ਸਹੀ ਆ ਬੈਟਰ ਨਾਵਲ ਕੋਲੇ ਭਾਈ ਵੀ ਆ
ਭਾਈ ਨਾ
ਮੈਂ ਕੋਲੇ ਪਾਉਂਦਾ ਜੀ
M3 ਦਾ ਤਾਂ ਫਾਇਦਾ ਹੀ ਨਹੀਂ
ਉਹ ਬਸ ਵੀਡੀਓ ਵਾਸਤੇ ਠੀਕ ਹੈ ਜੀ
ਉਹ ਤਾਂ ਲਾਈਵ ਲਈ ਖਰੀ
ਨਹੀਂ ਹਰ ਇੱਕ ਨੇ ਪਾ ਲਿਆ ਨਿਕੋਨ ਦਾ ਜਦੋਂ ਬੈਟਰੀ ਬੈਕਅਪ ਵਧੀਆ ਹੁੰਦਾ ਜਦੋਂ ਬੈਟਰੀ ਬੈਕਅਪ ਵਧੀਆ ਹੁੰਦਾ ਤਾਂ ਲਾਈਵ ਵਾਸਤੇ ਬਹੁਤ ਘੈਂਟ ਫੋਨ ਹੋਏਗਾ ਮੋਬਾਈਲ
ਕਿਹੜਾ ਕਿਹੜੇ ਕੈਮਰੇ ਚ
Z52
ਅੱਛਾ ਕੀ ਕਹਿੰਦੇ ਵੀ ਇਹ ਚ ਸੈਂਸਰ ਉਹਦਾ ਲੱਗ ਗਿਆ
ਰੈਡ ਦਾ ਲੱਗ ਗਿਆ
ਰੈਡ ਦਾ ਲੱਗ ਗਿਆ
ਹੁਣ ਚੇਂਜ ਨਹੀਂ ਕਰ ਸਕਦੇ
ਰੇਡ ਨਾ ਉਹ ਤਾਂ ਜੋ ਇੱਕ ਵਾਰੀ ਮਾਰਕੀਟ ਚ ਆ ਗਿਆ
ਘੱਟ ਪੈ ਗਿਆ
ਨਹੀਂ ਘਾਟਾ ਨਹੀਂ ਪਿਆ ਉਹਦਾ ਬੈਟਰੀ ਬੈਕਅਪ ਹੈ ਨਹੀਂ ਤਾਂ ਕਹਿੰਦਾ ਜਦੋਂ ਬੈਟਰੀ ਬੈਕਅਪ ਹੁੰਦਾ ਨਾ ਉਹਨੇ ਸਾਰੇ ਫੇਰ 10 ਦਾ ਕਰਾਇਆ 200।
Good morning, Chairperson, distinguished speakers, esteemed faculty, and dear delegates. It's a privilege to welcome you all to this academic session of PIMACON. CME programs like this remind us that learning in medicine never stops. It evolves with every discussion, every innovation, and every shared experience. We are truly honored to have such eminent experts with us today. Let us begin this session with enthusiasm and a commitment to excellence in medical practice. Dr. Saurabh Mittal and Dr. Himant Gopal to kindly join us on the stage. We are privileged to have a paradigm for osteoarthritis from replacement to regeneration. With decades of clinical excellence and a steadfast commitment to restoring mobility and improving quality.
Thank you, Dr. Chabra. At the outset, I'd like to thank Dr. Chabra and his team for having me here to share my experiences. Respected chairpersons, I'm here to talk about knee replacement. How are we managing our knee pain today? Let's start with that. For quite a few years, 5 years, 10 years, our prescription basically remains the same, which is pain relief, supplements and physiotherapy and maybe an injection here and there, till it becomes an advanced arthritis, and then we happily advised TKR, we are happy and the patient is happy. Is this victory or defeat? I believe it is defeat of orthopedics. And like me, there are many more in the world who believe that TKR has been a revolutionary operation, no doubt, but it is a defeat of orthopedics, medicine and science. We rather take pride in changing our tools from power tools to patient-specific instrumentation, to computer navigation, to robots and now humanoid, AI, VR and ARs. I asked a question to myself, and I asked the same question to my fraternity also. Is our focus more on machines and less on biology? Should we not be working on stopping the progression of disease? And that is the question I'm going to address today for my talk. There is no conflict of interest in my talk. And my talk is mostly science, maybe a bit of common sense, but no commerce. Friends, reviewing the present treatment again, analgesics, physiotherapy, injections, brace, and this journey continues for 5 to 15 years. Apart from it becoming an insensate knee, and we claiming that 95% survival of the implant at 15 years, 20 to 25% patients remain unhappy with a successful operation also, and this is universally accepted and reported. Sorry. Now, apart from this, periprosthetic fractures is a pandemic waiting to happen. What is more concerning is that 1 year mortality after periprosthetic fracture can be up to 45%. Then revision knee surgeries are increasing about 600% every decade, with decreasing success rates and higher complications, higher morbidity, higher risks. Friends, unhappy total knee replacement. This is a book published from Germany. We are not the only ones thinking on follow-up. That dissatisfaction rate after total knee replacement, the so-called successful total knee replacement, can be up to 20 to 35%, depending on the age and severity in the patient. So there is a significant number which are dissatisfied. It is now, public is also realizing, this is an article from Times of India and National Daily last year. So people in the society, around the world, in the fraternity are coming to realize that a successful total knee replacement doesn't mean a satisfied patient. Osteoarthritis is a painful and disabling disease, and knee osteoarthritis is going to become the most common cause of orthopedic pain in very near future. And the paradox is that we have no accurate tool for predicting the risk or onset of osteoarthritis, nor we have any approved medication to stop the progression of disease. And that is a big paradox. And when I wanted to see why it is so, and I wanted to dig deep into osteoarthritis as a disease, I looked at all aspects of osteoarthritis, read about 4,000 articles published in the last 20 years. What is the etiopathogenesis? I realized that all aging knees are not same. Some develop osteoarthritis and some do not develop osteoarthritis. Now, which are those who develop osteoarthritis? There are a variety of factors which predispose a person to develop osteoarthritis, and these factors can be local or general. And these factors can be mechanical or biological. Some of these factors can be modifiable and some of them are non-modifiable. So how do we manage that? For that, we need to know what is actually the disease process, the pathogenesis. What is the pathogenesis of the knee? In last 15 to 20 years, studies from around the world, including Stanford and all big centers around the world, from America, from Europe, even from our country, it has now been established that osteoarthritis knee is a chronic low-grade inflammatory disorder which is slowly progressive, and there is immune-mediated pathology. In other words, osteoarthritis knee is a local manifestation of a chronic systemic inflammatory disease. There is a local inflammation and systemic inflammation, both. Therefore, osteoarthritis and rheumatoid arthritis are two ends of the same spectrum of disease process. The only thing is that the inflammatory markers are not raised very high in osteoarthritis, so the tests remain negative. And I think one of the chairperson, my friend, that rheumatologist, would also agree with this. Even in biggest journals, the Joint Surgery, they have also subscribed to this. Friends, inflammation is nothing new. 22 years back, this was the cover of Times magazine, which put a red flag on inflammation, chronic inflammation being cause of the majority of non-communicable diseases in the body. Now that is when it was red flag. And last year, the Nobel Prize was also given to these workers from medicine whose work could find a solution to this chronic inflammatory disease, immune-mediated chronic inflammatory disease. So inflammation has been talked about quite a lot, and we are needing the solution for that problem now. Friends, what should be the treatment? Now that we have learned the factors which predispose a person, we have learned about the pathology, what should be the treatment? I think osteoarthritis, if we know, is a local manifestation of chronic systemic inflammatory disease. The treatment should be no-brainer. The treatment should be both local level, which has been involved, and systemic treatment. We should target the chronic inflammation. That makes a 360-degree treatment for osteoarthritis knee. Friends, in the last 2 decades, there has been significant progress in the treatment, local treatment, and that has been quite standardized to an extent now, with the advent of regenerative medicine and orthobiologics becoming established branches of medical science. Evolving very fast. Many clinical trials are in different phases in different centers around the world. So friends, what is the local treatment? Local treatment has to be biological and mechanical. Biological treatment, the structures involved. What are the structures involved in knee osteoarthritis? Only then we will be able to target those structures. Traditionally, we have been thinking that osteoarthritis is just wear and tear of the cartilage, but it is not so. It has been proven that all the structures in and around, be it synovium, subchondral bone, cartilage, fat capsule, or tendons, all these tissues have been biopsied and have been shown to have increased inflammatory markers. So all these are involved in inflammation, and they should all be treated. So friends, local biological treatment at the moment, autologous biological agents from blood, from bone marrow and fat, in variety of forms have been tried and are being used routinely at many centers in the world. Many countries have approved their use in clinical practice. Allogenic biological agents also from bone marrow, placental tissue and umbilical cord have shown very good results, and even in India recently, many other countries, Japan, South Korea, these other products are already approved. Now a new molecule, ozone. It's not a new molecule, but the new thing is that intra-articular use of ozone injection has been proven to be anti-inflammatory and regenerative abilities. So that has also shown very good results in osteoarthritis of the knee. Now, I will just show one study of the biological treatment of the osteoarthritis knee in a patient with bilateral osteoarthritis knee. There are 2 studies. This study with 75-year average age. One knee treated with biological method and one knee treated with total knee replacement. 15-year follow-up in the same patient, same condition, everything same. The knee treated with biological treatment was much, much better, be it complication, be it revision. So after this, it is the biological treatments have taken on regeneration and restoration. Now we have now doing a very novel method, minimally invasive, no incision, no surgery, no anesthesia, no stitch. Here we apart. And this is our biological treatment for the local, target joint. Mechanical treatment, these medicines cannot correct the deformity. For that you have to go to surgery, which can start with conservative treatment or brace or needleplasty or osteotomy, and finally TKI. All these things are needed for correcting the malalignment if it is very severe. So our practice to control the systemic process is low dose, low frequency DMARDs, and then we also treat other comorbidities like osteoporosis, metabolic imbalance, coma, lifestyle changes. All these are a part of patient at that age, and we treat all that. One thing we need to remember that since it's a chronic inflammation, like any other chronic disease like hypertension, blood pressure, diabetes, hypothyroid, the treatment has to continue for a long time. Only the doses can vary depending on the activity level of the disease. At the same time, we cannot promise any miracles to the patient. We cannot prevent aging. We can only prevent quality of life. So the expectations have to be moderated. The surgeon, the doctor, and the patient should have shared expectation, then none of them will be disappointed. This is our low dose, low frequency anti-inflammatory regime. One of my close friends, Dr. Mukherjee, who was with me in Liverpool, has been using similar regime for close to 3 decades. And this is very safe, very effective, but it needs to be personalized and individualized. And doses keep on going up and down depending on the activity level of the disease. Friends, now, when a patient comes to us different stages of knee osteoarthritis, our basket of treatment options is full of variety of treatments, be it biological, be it mechanical, be it injectable, be it other thing. However, if patients come so late, we have bone loss, deformity, loose bodies, fixed deformities, we have to do TKR, and we do TKR, and patient is very happy after this because they are very disabled before this. Now, in last 1.5 years, with this, our regime, we have treated about 202 knees. Out of those, only one has no pain, climbing up and down the stairs, no painkillers, doing all activities of daily living, cooking food for the family, going on holidays. So friends, this was unimaginable. We could not ourselves believe that this was possible. I had in fact refused to do the treatment for her because she was very advanced, but then she said, no, I can't do knee replacement, so you try whatever you have. This is another patient. For 10 years, gradually increasing pain, frequently on wheelchair, whenever she had to go for anywhere. First she booked wheelchair, then she booked the ticket. You can see bone on one side, and 2 years after the treatment, how the cartilage restoration has taken place, the deformity is corrected, no pain, no problem, doing all activities of daily living without any handicap. So these are the results which have encouraged us. Friends, in future, if I go by the researches and the studies that are being published, personalized and targeted therapy for knee osteoarthritis will be available depending on knee phenotypes. Intra-articular gene therapy, only last month there was an article from Mayo Clinic, very good results. And with modern lab tests, machine learning and artificial intelligence, osteoarthritis, if we can predict, we will be able to prevent also. Friends, biological joint reconstruction in this day and age is a viable and realistic goal with regenerative medicine and orthobiologics. My prediction, therefore, is that in the next 5 to 10 years, conservative treatment of osteoarthritis, both local and systemic, will be more evolved and routinely advised with the objective to help restoration of cartilage and slow down the progression of osteoarthritis. In next 10 to 15 years, the number of knee replacement surgeries will go significantly down, just like what has happened to rheumatoid arthritis. When I started knee replacement, my major patients were of rheumatoid arthritis. Today, it is osteoarthritis. And in 10 to 15 years, here also the number of knee surgeries will go down. Friends, my message for my fraternity today is, can we prevent osteoarthritis? Not yet. Can we slow the progression of osteoarthritis? Yes. Can we help restoration of cartilage? Yes. Can we put the disease into remission? Yes. Can we postpone TKR? Definitely yes. We are doing it every day in our practice. Can we avoid TKR? Yes, it could be possible if we can start treatment early and patient agrees for it. So friends, my call today is, let us save our knees for as long as possible. Thank you. And my last is an invitation to everyone to come to Ludhiana next weekend. We are organizing a unique conference where orthopedics beyond books and multi-specialty integrated approach is going to be discussed. Thank you again. Thank you.
Thank you so much, sir, for a very indulging talk. And as rightly mentioned, cartilage preservation and cartilage conservation is the... Any questions from the house?
Yes, Dr. Chavla, thank you. Very tricky?
Very tricky topic.
Yes.
There's always a debate between a surgeon who is more fond of doing knee surgery and the person who is treating also arthritis in a conservative way. So मैं एक patient के point of view से पूछना चाहता हूँ सर कि या एक layman के how do we counsel the patient जो ये कहे कि डॉक्टर साहब मैं 15 दिन औखा हो लूँगा मेरी knee surgery हो चुकी मैं 15 दिन औखा हो लूँगा कोई बड़ी गल नहीं पर जिंदगी भर दवाइयाँ लेना मेरे वास्ते थोड़ा सा औखा काम है. How to counsel that type of the patient?
Yes, good question, good question. Pehli baat to Dr. Sahab, first thing, there was nobody as enthusiastic about knee replacement as I have been. When I started, there was hardly anybody doing knee replacement, and when I used to tell the patient, you know, कि आपका knee replacement है तो वो कहते थे बेबी ना मजाक करता डॉक्टर. So, you know, I still do knee replacements. It's not that I don't do knee replacements. The question is how to counsel the patient. You know, the knee replacement doesn't do anything to the systemic disease. That is number one. Knee replacement is only a local mechanical treatment. So, if the patient says, मैं 15-20 साल दवाई नहीं लेनी, but knee replacement of the systemic disease that he नहीं. Don't treat just the knee. Go ahead, do anything. Just the knee is also being treated by biological and mechanical methods that I have just outlined. That can also be done. That can help delay the treatment, delay the knee replacement, or postpone if we start very, very early. I mean, avoid if we start very early. But in early stages, patients normally don't start the treatment. So systemic treatment is not targeted to the knee only. Systemic treatment is targeted to this chronic inflammatory process which is in the body. And it is the same inflammatory process. If it targets pancreas, you get diabetes. If it targets blood vessels, you get hypertension. If it targets heart, you get heart attack. So it is the same systemic inflammation, chronic systemic inflammation. So that is what are the recent discoveries, and that is why the Nobel Prize last year for this, that their work will tell us the treatment for chronic inflammation, which will target all these non-communicable chronic diseases.
So, what is your experience with PRP injections?
Yes, I have used PRP for some time. PRP usually I found they were very painful. So I left PRP and I went on to the next stage. For last few years now, from PRP, and they stimulate the cartilage cells and the bone cells and stem cells. So, and if we take, let's say, 100 platelets in the joint, out of those 100, maybe 10, 15, 20 die, 10, 15, 20, little bit growth factor come out, 10, 15, 20 more growth factor come out available, that we can take that PRP and extract the growth factor under ideal condition outside the patient. And that is what I do. I extract the growth factor and then inject the growth factor directly. It is acellular, there is no pain, there is no inflammation, and we get almost more than 95% yield of growth factors from platelets. So this is an advancement over PRP, but basic thing is similar. Thank you. Sir. 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 Sorry?
People at the back can't hear. Mic borrow kar leंगे आप?
And then people at the back can't hear.
Sir, as this is a systematic disease, in the localized painful in the knees, can we say that knee replacement is a symptomatic treatment?
Yes, I have shown that.
It is all like in fever we give only paracetamol treating any...
No, paracetamol has got many side effects, long-term paracetamol. and knee replacement on the other hand got some risks. But there is no long-term medication for local symptoms. Knee replacement is one-time surgery, and it has been a revolutionary surgery. There is no doubt about it. But at that time, the pathology was not exactly known. At that time, we were adult. Like I said, I have seen myself over 30.
Learn those techniques. Even non-orthopedic people can do this one. Learn those techniques. Even non-orthopedic people can do this one. Sir, आप better बता सकते हैं.
No, take it. That's fine. Thank you. Without painkillers. That is one of the sessions. That we discuss with the international experts.
Thank you, sir. Your valuable perspectives have greatly enriched our understanding and will certainly guide us in improving patient care. I now invite our chairperson, Dr. Saurav Mittal and Dr. Hemant Gopal, to kindly present a memento to our distinguished speaker, Dr. N.K. Agarwal, as a small gesture of our heartfelt thanks. I would like to invite Dr. V.S. Jha, the senior-most neurosurgeon in Bathinda, to kindly come on the stage to facilitate our Honorable Chairperson Dr. Saurav Mittal and Dr. Hemant Gopal.
Good afternoon, everyone. A third year MBBS student at AIMS Bathinda would like to request our Honorable Chairperson, Dr. Surinderpal Kaur Sidhu, Director of Dr. Akhtiar Dil Hospital, Dr. Saurabh Gupta, MCH Urology, Professor at Adesh Medical College, and Dr. Usha Goyal, MS General Surgery, DHO at Civil Surgeon Hospital, to please join us on the stage. It is my honor to invite Dr. Arvind Sharma for his talk on scope of gynecologic surgery and place of hysterectomy. With vast clinical experience and deep insight into modern gynecologic practice, Dr. Sharma brings valuable perspective on this important and evolving subject. Sir, we are honored to have you with us at PIMACON and look forward to your enlightening session. A very warm welcome to sir.
Hello, good afternoon, friends. To begin with, I'm grateful to our organizing team, the main executive organizing team, to give me this opportunity for this small talk, which I believe is going to be clinically useful. This is not an academic talk of the nature of research or new findings. This is relevant to practical clinical practice. Hysterectomy, as you know, in gynecology, is one of the useful operations, but over several years, the developments have occurred which have brought the procedure into disrepute. So we dwell on to this, and then the other purpose of my talk is to dispel the misconception that the performance, rather than the entire philosophy encompassing the physiology, the pathophysiology of the disease, which we should know. So, we'll do well to remember that there are two well-known sayings in surgery, in any surgical branch. First is choose well, cut well, and get well. So choose well means you must have proper indications, you must have properly selected cases. Properly selected cases. Cut well means your technique should be good, and get well. That's the way to recovery. And the other thing is indications. There are only 3 indications for all kinds of surgery in every specialty. What are those 3 indications? One is to save life. Second is to relieve suffering. and third is to correct deformity. ये तीनों में ही आती हैं जो भी बीमारियां हैं, मतलब whatever we treat by surgery in any surgical specialty, to save life, to correct deformity, and to relieve suffering. Well, now we come to the main point that in gynecology, with the specialty which we call OBGYN, that we have three main areas of endeavor, and most of the practitioners concentrate on one of these. Obstetrics is one field which is very important from public health point of view. So most of the times those who have good obstetrical practice don't get to devote attention to aspects of gynecological surgery. ART is another field of endeavor in gynecology, assisted reproductive techniques, which means mainly IVF, in vitro fertilization and reproductive medicine. The gynecological surgery as such is the third field of endeavor which is a part of this specialty, and that because the attention of the trainee is taken over by obstetrics and aspects of IVF, etc. So sometimes in certain situations, I'm not saying everywhere, but the surgical training suffers. And secondly, here which I have, one of the general surgical colleagues several years ago, he borrowed gynecologic surgery, textile surgery. Hysterectomy should be something like 300 pages. So surgery, hysterectomy should be something like 300 pages. So, well, that's not so. And other main point, my motivation for this talk is that during the past 15 or 20 years, we have seen hysterectomy being abused, misused due to various reasons, and being done without indications. That's why I said indication must be kept in mind to save life, to relieve suffering, and to correct deformity. Beyond this, we are perhaps not acting on indications. So it's a useful operation, but it is just a small part of gynecological surgery. Other thing is, in certain sections, even gynecologists, well, I'm discussing this because we are all, and we should be mindful of this, that we can do so many other things rather than just depending upon one procedure. And so we'll be, in short, discussing the alternatives which are available for minor problems, and hysterectomy is not the solution for so many problems in gynecology. There's a dubious distinction in India. Cervical cancer सबसे पहले हुआ था pap smear preventive oncology. Europe में, because in those days there was sexual promiscuity and incidence of cervical dysplasia was quite a bit. So the cytologist Pepper Nicolo, history in pathology, you know, exfoliative cytology was employed for screening for cancer, and pre-cancer stage में detect करके through government orders, every lady was screened. Lady means teenagers, including teenagers. They were screened. Pre-cancer was identified and treated by simple methods like cauterization or cryosurgery. And that's how the incidence of cancer cervix, cervical cancer, was decreased in the West. But we have been able to decrease the incidence by doing unnecessary hysterectomy. So hysterectomy is definitely, it has morbidities and adverse effects compared to very localized simple procedures like cryo or cautery. So gynecological surgery, basically, if we are are proponents of healthcare of women. So the main fields of endoscopy means for many conditions where open operations, laparoscopy was done earlier, hysterectomy solves the problem beautifully. So there are so many things, gynecology to be done, hysterectomy sabki honi chahiye. And other is spread of misinformation के कैंसर हो जाएगा तो 40-45 साल की उम्र में यूट्रस रिमूव करवा दो. There is no such thing in medical science. Unnecessary hysterectomies, especially special focus is that surgery on women under 40. Sometimes they are just doing if a lady has 2 kids, तो 30 साल की है, 35 की है, कब की है, she has come with any weight complaint, उसकी hysterectomy कर दो. That kind of attitude is too bad for, because we are doctors, we are claimed to be specialists. So these regulations आ गई हैं. ये शर्म की बात है हमारे लिए कि पहले तो इंश्योरेंस वालों ने मना कर दिया, फिर सुप्रीम कोर्ट में PIL हुई, फिर उसके बाद सेंट्रल गवर्नमेंट has had to frame regulations. Already gynecologists suffer from so many laws being applied to them, MTP Act, Ultrasound PC, PNDT Act, etc. So this is the 3rd act in the offing now, and there is mandatory reporting. It's a kind of reportable offence. It's not a surgical procedure that why did you do hysterectomy. Abhi implement nahi hua hai, shayad ho jayega, but then we need to be knowledgeable. So commonly cited indications these are the commonly cited indications: fibroids, dysfunctional uterine bleeding, chronic pelvic pain, genital prolapse, chronic pelvic inflammatory disease, and chronic cervicitis with or without dysplasia. Dysplasia is the pre-cancer cytological change before the occurrence of invasive cancer. All these ailments, first you have to give adequate trial for at least 3 to 6 months to non-operative medical treatment or conservative. That means without hysterectomy you can. So these are the methods available with, and every gynecologist should know this. Drug treatments are there, hormones of various types. Then we have hormone impregnated IUD, intrauterine device, Marina. Radioembolization is another method done by radiologists. Conservative surgery is, as I think the last presentation in orthopedics also was about the conservation. Conservative surgery is something which is the hallmark of a good surgeon. Rather than removing uterus, we can remove a cone of the cervix, or we can just remove the fibroid. We can do excision of endometriosis. Prolapse can be easily corrected by without removing the uterus. Prolapse correction अलग चीज है, uterus remove करना या ना करना अलग चीज है. So long-term adverse effects. This is the most important thing. When you do hysterectomy, especially in a young age, because ovarian blood supply is dual, it comes from uterine vessel as well as from the ovarian vessel. After you have removed the uterus, if menopause, that means cessation of ovarian function, deficiency of hormones occurs many years earlier. If menopause has to occur, say, at 47, 48 years of age, after hysterectomy, suppose you do hysterectomy at 40 years of age, 2 साल 3 साल में ovary function खत्म हो जाता है. Consequences of menopause are bad for the woman. Its vasomotor symptoms: hot flushes, genital atrophy, mood swings, depression, then long-term bone loss, atherosclerotic cardiovascular disease, cerebrovascular accidents. ये बुढ़ापा एकदम से आ जाता है. This is not a myth. This has been proven. And unexpectedly, some women may desire pregnancy at the age of 50 or so, like the famous Musewala case. Donor ovum IVF technique is available for the past 30 years. It wasn't available पुराने ज़माने में नहीं थी. Then in premenopausal women, hysterectomy does result in some decrease of coital pleasure. So time's up. Anyway, we'll gynecological surgery adopt laparoscopic, open or vaginal, a few procedures, and then I'll conclude. Surgery, this is radical hysterectomy, is also like that. So we should be, okay, the last slide is this, that doing unnecessary hysterectomy for the reasons I've explained is a disservice to women, and especially if we take pride in this, that we are providing very good service of international levels, then we should avoid doing this. And the last, on a lighter note, one of my friends, I am fond of शायरी, कभी कभार शेर सुन लेते हैं, तो क्या जो हिस्टेरेक्टमी छोड़ दी मैंने, मुझे तो और कोई काम भी नहीं आता. क्या जो हिस्टेरेक्टमी छोड़ दी मैंने, मुझे तो और कोई काम भी नहीं आता. Thank you.
The house is open for questions.
Yeah, any questions?
Because of time constraints, we'll take only one question.
Yes, sir.
If a woman who has already delivered 2 children at the age of 25, her uterus transplantation, is it possible?
No, yes, if on compassionate grounds, if she has someone close to
Uterus transplantation is possible है या नहीं?
to donate uterus.
किसी patient का भी हो.
Yeah, to donate uterus is possible, and it is still an experimental surgery being done.
Woman has lost uterus due to PPH.
Right.
And he wants a child.
Yes.
Can he get any uterus from any lady who has already many children in young age? My question is it scope of her uterus transplantation in future?
Is uterus transplantation justified? मतलब करनी चाहिए कि नहीं करनी चाहिए सर?
I think I cannot convey my question.
Sir, he's saying, sir, Dr. Sharma, he's saying that uterus transplantation is possible or not?
It is possible, yes. It's been done on experimental basis at several centers, even in India. कर सकते हैं. डोनेशन अलग गल है सर, जान के कटते हैं यूट्रस अट गल है. डोनेशन जिवें किडनी है किसी का जान के कट देना या लिवर कट देना जान के, वो वक्री गल है, ते डोनेट करना वक्री गल है जी, कंपैशनेट ग्राउंड पे.
Thank you, sir.
Thank you, sir. We are truly grateful for your valuable contribution to this academic gathering. Now I invite our chairperson, Dr. Surinder Gupta and Dr. Usha Goyal, to present a memento to our distinguished speaker, Dr. Arvind Sharma, as a small gesture of our heartfelt thanks. like to call Dr. Chitralekha Bansal, a senior gynecologist at Bathinda, to felicitate our chairperson, Dr. Surinder Kaur Sidhu, Dr. Saurabh Gupta, and Dr. Usha Goel. I invite the doctor who needs no introduction among students and faculty of AIMS, the most beloved professor, Dr. Akhilesh Pathak, Dean Academics and Professor and Head of Forensic Medicine and Toxicology at AIMS Bathinda, to kindly felicitate the chairpersons.
Thank you, sir. Now I, Mahendra, a third year MBBS student, am honored to invite chairpersons Dr. Indivi Kalra, consultant psychiatrist at Kalra Medical Care, Bathinda, and Dr. Anshul Gupta, professor and head of Department of Immunohematology and Blood Transfusion at Adesh Medical College, Bathinda.
ਯਾਰ ਲੈਟ ਤੇਰਾ ਬੰਦਾ ਉੱਥੇ ਰੱਖ ਦਿੰਦਾ ਚੇਅਰਪਰਸਨ ਦਿਖਾਣੇ ਹੁੰਦੇ ਬੈਠੇ
I would now like to call upon Dr. Pura to speak on the topic management of delirium in ICU and IPD. Dr. Pura has done MBBS and MD in psychiatry and currently works at MITA Neuropsychiatry and De-Addiction Hospital. He is the founder and consultant psychiatrist at MITA Neuropsychiatry and De-Addiction Hospital, Pura Mehta Manasik Swasthya Private Limited, and Dr. Mehta Neuropsychology. Sir, we are privileged to have you with us and we eagerly look forward to your valuable insights. A heartfelt welcome to you.
सिविल में है आप? हाँ, पहले सिविल में नाइस मीटिंग यू.
Good afternoon, everybody. Thank you, Dr. Vidya Shetty, for jolting everybody out of their seats. So, my presentation will be more perceptible. Thank you so much, organizers, for giving me this wonderful opportunity to interact with the learned audience. I'm thankful to my chairperson, my friend, and my younger brother, Dr. Indivar Karla, who is instrumental in preparing this presentation. तो सर अगर कोई गलती निकालोगे तो वो आपकी है, मेरी नहीं है. I'm taking the insurance. Management of delirium is a complicated topic. I would like to make it as simple as possible. And this is humble submission before I start. I'll be working mainly on hyperactive delirium. Most of the emphasis of management are on elderly people, but in general principle applies the same. I have deliberately avoided the criterion scales because in hours or days, symptoms may fluctuate depending on the awareness, attention, orientation. Then cognition. Cognition includes memory, executive function, and judgment. This basically reflects decomposition of whole cerebral functions. We should anticipate delirium, especially surgeons sitting over here, physicians sitting over here. We should anticipate delirium because it's very important to expect delirium. Why it is important? because people in hospital or long-term care, they are at risk of delirium. It can be a precursor for dementia. Emissions. In elderly, delirium precedes death. It's missed in most of the cases. Global cerebral function may never return to normal, despite a very common saying that delirium is completely reversible. It's almost 82% in ICU pairs. It's very common. What are the clinical features? Acute onset of symptoms with a fluctuating course. Types of symptoms are cognitive, neurocognitive, and motoric symptoms. What are cognitive symptoms? Cognitive symptoms includes disturbance in attention, memory, orientation, comprehension, vigilance, visuospatial abilities, and executive functioning. Then its inability to mobilize, shift, and sustain attention. Memory includes both short and long-term recent memory. Then there is disorientation of time, place, and person. Then non-cognitive symptoms is a disturbance of sleep-wake cycles. It may be reduced arousal, or it may be total loss of sleep. Disturbance of decreased, depressed mood, isolation. Then dementia, depression, elderly abuse, isolation. Then dementia, depression, elderly abuse, and previous history of delirium. Then other factors are polypharmacy, pressure ulcers, sensory impairments, pre-morbid state of inactivity, poor functional status, falls. These factors that can actually precipitate delirium immediately, they are acute insults, dehydration, fracture, hypoxia, infection, and ischemia. Then medications, almost any medication can precipitate delirium. Metabolic derailments, poor nutrition, severe illnesses, shock, surgery, or uncontrolled pain. Urinary and stool retention, that's very common cause of delirium, it's usually missed. Then environmental exposure to intensive care unit settings can cause delirium, sleep deprivation can cause delirium. So this make you remember that following these things can cause delirium. Pain, persistent pain that is not being managed, infection, nutrition, constipation, hydration levels, medications, and environment can cause delirium. So practically anything can cause delirium. Any medication, almost every medication can cause delirium. There are those medicines that are high risk are antihistaminics, muscle laxatives, antipsychotics, benzodiazepines, dopamine agonists, and meperidine and opiates. What are the moderate risk? They are antibiotics, antimalarials, and anticonvulsants. Antihypertensive, especially beta blockers and clonidine, though the paper has documented in moderate risk, but they are very high risk causing delirium. Then moderate to low risk drugs are low potency antihistaminics like proton pump blockers, then metoclopramide, then narcotics other than meperidine, NSAIDs, TCAs. It's a very simple assessment tool, known as CAM, confusion assessment method. You have to see 4 features. First 2 are essential, and there should be 1 feature from the next 2. First is acute onset. Has the patient's mental status changed abruptly from baseline? Did the abnormal behavior fluctuate during the day or the night? In addition, has the patient got difficulty in sustaining attention, or he is easily distracted? Then disorganized thinking. Was the patient thinking disorganized? It can be seen by his incoherent speech, rambling of his words, then irrelevant conversations, switching of subjects from one to the other. Then altered level of consciousness. Patient should not be alert. He should be either hypervigilant, or he should be easily aroused, drowsy or lethargic. He should be or difficult to rouse. A normal alert patient is not delirious. For assessment of delirium, first part of delirium is non-pharmacological and pharmacological management. More important is non-pharmacological. How should we manage delirium without or minimizing the drugs? In general principles of management is we should maintain fluid and electrolyte balance. We should treat hypoxia, treat underlying infection and causative illness, check for bowels and bladder, avoid physical histories. ये 5 पॉइंट्स हैं जो आप अगर प्रॉपरली ध्यान रख लोगे तो आपका पेशेंट डिलीवरी में जाने के चांसेस भी कम रहेंगे और मैनेज करना भी आसान रहेगा. We should first of all we should provide support and orientation. कुछ ऐसा होना चाहिए जिसको पेशेंट को पता लगता है कि अब दिन हो गया, अब रात हो गई, शाम हो गई. This better is patient we should can keep the bed near the window. Something else can be done. We'll explain later. Communication should be very simple. We should communicate to the patient in clear and simple language, not in medical jargon. Discuss topics which the person of delirium is interested in talking. His hobbies, his profession. Reorientate the patient by repeatedly reminding of the day, time, location, and identity of the key individuals, including your staff also. Understand the person's emotional state and encourage him to speak. Provision of calendar, clock or chart in day's schedule is very important. We should, for the patient with delirium, we should keep a calendar in his daily room. We will keep it daily. Whenever you go to the round, you should point out today is this day, this date, this month. Bring familiar objects जो patient घर पे जैसे किसी specific तकिए के साथ सो रहा है या किसी specific कोई specific bedsheet है उसका या कुछ specific कोई book है, that should be available for him. Minimize change of staff. मैं हमेशा ये कहता हूँ आपके जो पेशेंट के लेटर्स भी मिनिमाइज चेंज करो. मैं कहता हूँ कि 1 या 2 दिन रखो, बार-बार नए बंदे ना आओ ताकि पेशेंट कंफ्यूज ना आए. Restrict to visitors, only close family members should be around. In fact, those who are caring the patient prior to the illness, like maybe his caretaker, maybe his servant, they should be brought to the hospital. Physical restraint should be kept away if possible. When used, should be for the shortest possible time. Do not contradict the patient's delusional belief. Do not confront and disagree with the patient. Avoid having more than one patient with delirium in the same room. हमारे सर क्या करते हैं 2 महीने के पेशेंट कभी भी इकट्ठे मत रखो, पक्का लड़ाई करेंगे. Because one person starts stimulating the other. Similarly, if you have 2 agitated delirium patients, don't keep them in the same room. Avoid both sensory deprivation and sensory overload. Because if patient is wearing glasses and patient having hearing aids, if he is not using that, he may not be able to perceive the proper information that you are communicating. Similarly, if patient is staying in ICU, keep the noise alarms minimum, or you can shift the patient to an isolation room. Encourage daylight exposure. पंजाबी में पेशेंट ने कर दिया सुझाना भी मरीज को रोज रब दिखाना जरूरी है. So if possible, पेशेंट अगर एम्बुलेटरी है उसको व्हील चेयर पे एक बार बाहर जरूर घुमाओ. हॉस्पिटल के बाहर से सड़क पे लेके जाना पड़े. That makes his orientation very easily. उसको आप डे नाइट ओरिएंटेशन कर सकते हो. आपको प्लेस ओरिएंटेशन आ जाती है, पर्सनल ओरिएंटेशन आ जाती है. Frequent change of location of patient bed should not be done. In fact, अगर ICU में पेशेंट है तो इस पेशेंट को आप किसी कॉर्नर में एक स्पेसिफिक जगह पर लगा सकते हो ताकि बाकी लोग डिस्टर्ब ना हो और इसकी वजह से ये बाकी लोगों से डिस्टर्ब ना हो. If possible, provide a single room. Coming to drugs, most important thing is जो भी दवाइयाँ चल रही हैं उनसे जो भी बंद कर सकते हो वो बंद कर दो. Thank you. We had. So जो भी आपकी मेडिसिन चल रही है उनमें से जो भी आप कम कर सकते हो, they should be minimized ongoing drugs. Then we can use benzodiazepines, antipsychotics, and medicines for sleep induction. There are 3 main categories. Most preferred benzodiazepines is lorazepam. It's a drug of choice for alcohol withdrawal delirium. It prevents alcohol withdrawal seizure also. Dose is 1-2 mg orally or IV. It can be repeated as many as times possible. If the patient is allowing you, there is no respiratory depression. There are no other conditions. Thank you. It should be avoided in hepatic encephalopathy, hyperactive delirium, and other encephalopathies. Usual dose for alcohol for an adult with 70 kg, 12 to 16 mg we go up to 16 mg. There are 4 main drugs we recommend for delirium. First, gold standard is haloperidol, 0.5 to 1 mg, very low dose. You can repeat it 5 to 10 times up to 20 mg every 30 to 60 minutes. IV, IM or oral. We should look for EPS, that's very common, extracellular side effects. QTC prolongation and neuroleptic syndrome can be prescribed with haloperidol. For NMS, you should have a baseline CPK NAC level, CPK NAC level. As the CPK NAC level rises, we should always think of NMS and we should stop haloperidol. It should be totally avoided in alcohol withdrawal delirium because it precipitates further respiratory agitation. Olanzapine 1.25 mg TID or 2.5 mg BID up to 20 mg. It can impair your blood glucose level. It can precipitate metabolic syndrome like QTc prolongation. It's a preferred drug for delirium with Parkinson's and delirium with LBD. It is a preferred drug for elderly. Quetiapine 12.5 mg to 25 mg BID to TID up to 100 mg. Main purpose is reducing the agitation, making the patient sleep, and it can also precipitate metabolic syndrome like QTc prolongation. Risperidone, it's a strong antipsychotic with high potency, 0.5 mg to BID. It can cause akathisia, very important side effects, which usually patient becomes restless after risperidone. It can cause EPS, it can cause hyperprolactinemia, and should be avoided in young females. Now that is very important slide now. Medicines for sleep induction. There are 3 medicines that can be used. First, I'll speak of the last line. Zolpidem, very commonly used, should be avoided in delirious patients. In case it can increase delirium, it can precipitate agitation. Zolpidem should be avoided. Otherwise, drugs can be used as melatonin. We can use it for 3 to 10 mg. It's a very safe drug. There is no respiratory depressions. It can be used as an adjuvant to benzodiazepines in college. Then Lamborexant, it's not so commonly available. It is a dual orexin receptor antagonist. It has got a different mechanism of action. बाकी सारी दवाइयाँ आपको सुलाती हैं, ये आपके जागने वाले सिस्टम को स्विच ऑफ कर देती है. So sleep is a kind of associated effect. It actually stops RS, switches of RS. It does not cause respiratory depression, very safe drug. Then there is trazodone. It should be avoided in the elderly because it can cause urinary retention, anticholinergic side effects, and it can cause priapism. Alcohol withdrawal delirium, that is very commonly encountered in our hospital settings. Early or slow IV every 2 to 3 hours till the patient sleeps. Thiamine should not be skipped at all. Up to 500 mg IV 3 times a day, then 2-3 days for the 2-3 days, then 250 mg IV for 2-3 days, then 100 mg IV TID till the patient is in the hospital. Use melatonin 10 to 30 mg at bedtime. In alcohol withdrawal, you can use melatonin in the daytime also, 10 mg in the morning also. Quetiapine 25 mg and Lamborexant 5 to 10 mg in the addition to melatonin for sleep. Once again, I will say avoid using Serenase in alcohol withdrawal delirium. Treatment of hypoactive delirium, main encouragement should be non-pharmacological. Following drugs, epizole in 2 to 10 mg, methylphenidate and modafinil can be used to make the patient active. Prevention of delirium is very important because it's more easy to prevent that rather than treat. Evaluate the cognitive function at the baseline, monitor functions daily, take measures so that patients adequate sleep and encourage normalize your sleep as much as possible. Minimize exposure to medication which have high potency to cause delirium. Try to cut down the total number of medicines. Adequate pain management, reduce immobility, encourage independent ambulation of the patient, avoid use of physical restraints, avoid constipation, urinary retention, minimize use of indwelling urinary catheters. Environmental factors that should be important for preventing delirium. Minimize sensory deprivation. Restoration of eyeglasses and hearing aids. Sensory overload should also be avoided. Try keeping the patient in the bed near to the window and avoid frequent changes in the bedroom or run staff also. Frequent reorientation by using visible and verbal cues like seeing and hearing available, making that all the aids are available and staying hydrated. Progressions of delirium. Delirium can permanently lead to alteration in
Sir, time is up.
So that 2-3 slides more. Delirium can lead to impaired function activities of daily living, impaired function in the instrumental activities of daily living. Patient की cognitive decline हो जाती है, check sign करना है, क्या अपनी dates appointments याद करनी है. There is always a poor recovery after hip fracture. High rate of readmissions after delirium within 6 to 12 months. Persistent problem with memory and other aspects of cognition. They have permanent memory impairment. High rate of incidence of dementia in those not having dementia. worsening of dementia in pre-existing dementia and high rate of deaths. What are the recommendations? We all should, all of us should train our nursing staff and this home health aides so that they can identify delirium at the earliest. We should train them so that delirium should be prevented because of these simple things like stimulating the mind and moving around the patient at home. Assessment of prevention of delirium should be done at the day of the admission. Multi-component prevention methods for effectively deterring delirium episodes. Antipsychotic medication should be used as the last resort in treating delirium and should not be used indiscriminately in persons with delirium who have not been properly evaluated. So we should anticipate delirium. Usually it develops second or third day. Prevention is more comfortable. It's not like prevention is better, it's more comfortable for all of us and the patient and the relatives also. So prevention should be done than treating. Non-pharmacological management should be, role of non-pharmacological management should not be undermined. Treat it judiciously by minimizing polyformation. This is my references. There are certain criteria if somebody would like to know, but I deliberately avoided this because it creates more confusion than helping management. Thank you so much.
Thank you, sir, for lucid and this presentation. Any questions from the audience?
Ji, Dr. Please, somebody help and the mic to Dr.
So you told that we should use antipsychotics judiciously.
Yes.
Sir, for once the delirium gets over in ICU setup, patient gets shifted to the ward, then for how many days we can give the low dose of antipsychotics?
I think we should reduce it in 5 to 7 days. We should stop it. If it has been prolonged delirium, we can continue. But if it's 5, 7 days, 10 days, we should reduce it in 5 to 7 days. That is my practical experience.
Sir, and in risk factors for this delirium, you told that it is antipsychotics as a risk factor.
Yes.
I think it
Low
should
pressure
be
antipsychotics.
high dose of antipsychotics, I think should be the risk factor.
All low pressure antipsychotics can cause delirium. It's a double-edged sword, basically. Thank you so much.
Thank you.
Practitioner in the ICUs, we usually routinely see patients who have a long stay of more than 5 to 7 days. They usually go into ICU psychosis, a well-known identity. So in that case, we usually prefer or we identify a patient like when we come to know that he or she might go into psychosis, we prefer to give clonazepam in the night so that the patient sleeps well if the conditions are allowed as per the medical conditions. So, clonazepam. So is it safe and can we easily use this medication?
Clonazepam and lorazepam.
Clonazepam. Yeah.
Both drugs are safe, first of all. But more important is we should prevent it. You can encourage normal sleep. अगर आपके पेशेंट एम्बुलेटरी है, अगर आप उनको थोड़ी देर के लिए आईसीयू से बाहर डाल सकते हो, चाहे आपकी लॉबी में जहाँ पे थोड़ा बहुत डे लाइट आती है, तो दैट इज इम्पोर्टेंट. थोड़ी देर के लिए बाहर डाल सकते हो, उसकी फैमिली मेंबर्स के साथ रूटीन करके बातें करने के लिए, दैट इज इम्पोर्टेंट. थोड़ी देर के लिए उसको अंदर ही चक्कर लगाने के लिए अलाउ कर सकते हो इफ इट्स पेशेंट इज सिक, बिकॉज आईसीयू आर स्मॉल, यू गॉट ए वेरी बिग हॉस्पिटल, बट जो छोटे हॉस्पिटल जो आईसीयू होते हैं उनमें यूजुअली कोई लाइट नहीं होती, सारा दिन जो आर्टिफिशियल लाइट में patient is bound to develop delirium. So it's better to prevent it.
When the patient is having people who are admitted for some surgical procedure, when the patient is having people who are admitted for some surgical procedure or otherwise, at times we are called after 5 or 7 days of hospitalization and the patient is still having delirium. We tell them simply, if you can discharge the patient, we tell them simply, if you can discharge the patient, and there is nothing to be done from further from your side, you can consider discharging the patient if the patient is having minimum hyperactive delirium, so that the patient improves after going home, so that the day-night rhythm is restored. He will go home to the people where he is already staying.
2-3 important points है, sleep wake cycle, ambulation, hydration और अब daylight exposure बड़ा important है. आप शुरू से ही पेशेंट को डेलाइट एक्सपोजर करते रहो. अगर आपको लगता है मेरे को पता है इस पेशेंट को 4 दिन रखना है, दिन में एक बार उसको बाहर उठा दिया, है ना, तो यू विल
I now invite our chairpersons, Dr. Injivi Kalra and Dr. Anshul Gupta upon the stage to kindly present a memento to Dr. Mida as a small gesture of our heartfelt thanks. I now invite Dr. Baljeet Singh, Senior Radiologist of Bathinda, to felicitate the chairpersons.
I would now like to invite the chairpersons, Dr. Robin Khosa, Senior Consultant Radiation Oncology at Indraprasth Apollo Hospital, New Delhi, Dr. Atin Gupta, Founder and Director of Indrani Hospital with expertise in internal medicine and critical care, and Dr. Rohit Bansal, Medical Superintendent and HOD, Cardiac Anesthesiology and Critical Care, Delhi Heart Institute and Multi-Speciality Hospital, Bathinda, to grace the stage with their presence. Carrying the momentum forward, let's hear from Dr. Rohit Modi to expand on the topic Redefining Intervention, PCI to Precision and Beyond. Later, he holds the position of CEO at Modi Harvard Institutes and Research Centers, Senior Director of Cardiovascular Sciences at Park Hospital, Bathinda, Chairman and Chief of Cardiovascular Sciences at Clear Medi Group of Hospitals. We are truly honored by your presence today. And
just to kindly stick to the time, since we are already running very late, I would request chairpersons to keep the note of the time, and when we are left with 5 minutes, kindly let it know to the speaker so that he can stick to his time and fasten his presentation. Thank you.
Thank you very much for the kind introduction. I'm obliged to be here in this session of IMA. My topic today will be from wires to systems of care. I will go through the angioplasty and its advances, but I would try my best so that everybody understands. I know it's not a session of a cardiology session. So I understand that what the advancements in cardiology need to be undertaken, and we have done in efforts to bring it to 2-tier, 3-tier cities like Bathinda. So here we started with our humble practice, a Philips cath lab installed. Now it's the one that is the most adaptable to change. So we adapted to the rapidly occurring changes in a revolutionary manner, and I will discuss the advancements here. So first of the things, beyond IFR, and especially we have this with co-registration, then intravascular ultrasound with co-registration, QFR. QFR is a modality which is like IFR, and I'll go to better detail later, and the SYNC-VM. So all these things we have incorporated, seeing that the the societies, the worldwide society, which are known for cardiology, that's the European Society of the Cardiology, you see the flow goes very fast. So this is the same pressure gradient we measure with the wire, that is the IFR. Similarly, the class 1 recommendations, there are for intravascular ultrasound. We use it in our cath lab for left vein stenosis, true bifurcations, and long lesions. Then again, the class 1 recommendations now have come for QFR. QFR is a recommendations now have come for QFR. QFR is a quantitative flow ratio. This means that like we calculate IFR, as I told you, here we only take the simple angiogram, and from the angiogram, from the velocity of the flow of your dye, the computer can analyze it and give you a picture of a pressure gradient. That is called QFR. So it's simply an angiogram, and you know what is the pressure gradient. So similarly, why do we need extra invasive tools in our cath lab? So that make us wise whom to treat, what to treat, and how to treat. So these are the tools like FFR, IFR, whom to treat, what to treat, how to treat. IVUS with co-registration, I won't go into detail because otherwise it will be a long lecture. Then you can see a beautiful angiogram, and you can see the pressure gradient very well mapped there. On the angiogram, the greater the number of the dots, greater is the pressure gradient across the. Similarly, if you see intravascular ultrasound, I have put very simple pictures so that everybody understands that you can see a artery, intravascular ultrasound of the coronary artery, and in that you can see a stent, and you can see there is a gap between the stent and the artery. So, but on angiogram, it looks okay. It looks that you have removed the stenosis. But when you see with intravascular ultrasound, there is a gap between the stent and the. So this, if this thing goes in your heart, it can cause problems in the long run. We can have, the patient can have land up again with the subacute thrombosis, or patient can have restenosis. So by using these tools, we are improving the quality of our angioplasty. So that is the reason to incorporate. Then there is a synchronous. You have a precision guidance. You can see how much clearly you can see your angiogram. You can just enhance it. This is called enhanced angiography. You can see an enhanced angiography. You can quantitatively measure what we see on an image coronary angiography. Somebody might say it is 50%, somebody might say it's 70%. The one way is the pressure, to measure the pressure gradient. Other way is to see it very clearly in synchvian, and there you can see that the lesion is, computer says it's 62%. So this is the picture. You can see very clearly in the angiogram, it is enhanced image, and a computer measures your measurements, that is, it's 2.6 millimeters, 62%. So this is the X-ray on off. You can see even by applying your stent, you can have the movement on your computer screen. So you can see the picture of the stent very clearly. The balloon markers are seen. The stent is clearly seen. You can clearly see whether it has properly expanded or not. These things carry a important point, because they determine the patient's long-term prognosis. So it is documented that the use of imaging reduces event rate post-PCI from 4% to 1%. The use of IFR tells us whom to treat, when to treat, and why to treat. Similarly, QFR, I have just mentioned about it. It is especially used for intermediate lesion assessments, where we can, from the angiogram, see that this is there. Then the synchvian I have just described. These are the QFR pictures. You can see how beautifully you can just, by the computer, rotates it in all the angles. You can see your picture in all the angles and very clearly see. Because in a single angiogram, you might make the stenosis, maybe you can underestimate or you can overestimate. But these things, you get the pressure gradients, you can analyze in different views, so there's a less chance of error. Similarly, for going into the complex plasties like rota and IVL, you can see the use of the IVS in these situations, the use of the image enhancing in these situations, because you can see how the balloon expands. Complications, how we managed it, and we present it, we keep on frequently presenting it worldwide. The complex cases are there earlier were treated, which are earlier treated by CABG, now we can treat with a simple manner with a good long-term outcome. This is a CTO, case of a CTO presented, it's a complex CTO also. Then left main bifurcations, we are very happy to do these, we do almost routinely now, but thanks to the imaging and physiology, which is helping us to do these complex procedures. So these are the then left main bifurcations. Another important point I want to emphasize is ECMO. ECMO is a survivor and in very critical situations. Sometimes it turns the situations from death to life. It's useful in cardiogenic shock, poisonings, and ARDS. Never say no to life till it really ends. I remember a case of ECMO where a young female who with a poison came to us. Then her lungs were gone totally, and then we kept her on ECMO for 1 month, and then airlifted that patient to King's Hospital, Hyderabad, and then she got the lung transplantation done there and still surviving. So that is the importance of the ECMO. When everybody refuses that nowhere, the ECMO might be a lifesaver. When you go through deep waters, I will be with you, keep a watch. So these are the things which sometimes help out to come almost to help us to bring the even when everybody says it's a dead patient, come back. Now we are extending from coronaries to structural heart disease, especially aortic stenosis, functional heart, functional TR.
So last 4.5 minutes.
Just I'm concluding. Then the structural heart disease mostly now done is aortic stenosis, TAVI, the mitral valve repair has been started. Similarly, the tricuspid valve repair is now there. The minimal invasive heart, which can be done through catheter. So these are the techniques. Then another life support, as I told you, Impella, this ECMO. Similarly, for in the patients who have very poor LV function, this is very helpful. We did few cases with Impella also. These can be used in cardiogenic shock as well as the patients who are for high risk for PCI. So this is the TAVI. We are also looking into the neurointerventions. That is for the support of neurologists. With the help of neurologists and neurosurgeons, we make a team, and we have done few neurointerventions. Remove the clot from the brain. This is the mechanical thrombectomy we do with the stent retrievers. Now the suction machines are also available, which can the catheter can directly go into the brain and suck the clot out. So if you want to go fast, it is said, if you want to go fast, go alone. If you want to go far, go together. It's a very beautiful African proverb. So I would conclude by saying we always see these beautiful images in publications, presentations, but I am always reminded that behind every image there is patient, someone's mother, someone's father or sister or a brother. I mentor a lot of catheterization procedures, and they are, while it is a wonderful career path, my advice is never to forget the human side of what we do, and you will always be successful. Any researcher, any physician, any student, or any mentor who wants to
It was a nice talk, and I think you have combined all of the cardiology with the recent advances what are going on, mentioning especially about ECMO and Impella, and the house is open for questions. Anybody? So we have a cardiac anesthetist, Dr. Rohit, also with us. Dr. Rohit.
So, in my question, I want to ask, what are the actual indications for doing MR repair with intervention?
Yeah. Actually, this is presently not for primary MR. This therapy is evolving, and maybe we are later on doing for primary MR or the rheumatic MR also. But right now it is for secondary MR. The patients who are in heart failure with symptom class 3, class 4 symptoms due to secondary MR. This means there might be LV dysfunction, LV dilatation. Again, the LV dilatation in these patients should not be very severe. The MR should be disproportionate to the degree of LV. Suppose a patient of a very large LV, 6 millimeter LV internal diameter, and MR, that will benefit less than the patient with MR with relatively preserved LV architecture. So if we choose our patients correctly with the recommendations, this is a very wonderful therapy for symptomatic, and recently a trial has shown it to reduce mortality in these patients also.
So can you think it's the bridge between patient with
No, at present I won't say it has drastically changed our practice, but it is evolving. The beautiful rule I foresee is like the patients we get acute MR. You know, acute MR is a cardiac emergency, and as an anesthetist you must be knowing it, and it's a surgical emergency, you can say. Because surgery carries very high mortality, about 50, 60, 70% of the patients die even in the OT or just post-operatively. Such as the patients, I think, will be very, this therapy has started on these, the trials are ongoing. So this therapy, I think, will be very effective in these patients, because with transcatheter, we can repair these very high risk sick patients. So this will be an important role of mitral valve repair in these patients. And secondly, if we patients properly, we go with the criteria of the trials where this were used. This can be a very important therapy. And you know, like the angioplasty evolved, it was the first thing used was balloon, and ultimately it evolved and many things come. So it is just at right now in initial stages, the valve therapy, the structural therapy. Maybe down the line, 5 years, 10 years, you see a lot of structural and modified. We have technology coming into it, and definitely it's going to be a very exciting field. Yeah.
Thank you, sir.
Thank you. Thank you
very much. In the morning lectures, there was a question that, sir, please wait. In the morning lectures, there were questions like everything happens in US, everything happens in foreign countries, and we get to know only about the studies from the foreign countries. And I think with Dr. Rohit Modi is with us, not only in India, but we are blessed that he's in Bathinda with all of us, and we will get to see all these new techniques starting right away from our city.
Thank you. Thank you for the trust.
I now invite our chairpersons, Dr. Robin, Dr. Atin Gupta and Dr. Rohit Bansal to kindly present a memento to Dr. Rohit Modi as a small gesture of our heartfelt thanks. I now invite Dr. Jyot Ram Jain, Senior Most Pediatrician of Bathinda, with experience of 55 years, to felicitate the chairpersons.
Good afternoon, respected chairpersons, distinguished faculty, and I now invite Dr. Mara, MD Radiation Oncology, AIMS New Delhi. Sir is the first oncologist in Malwa region. He started his practice in GMC Faridkot and then serving people of Bathinda and Malwa region from last 20 years. Currently HOD Oncology Department in Pragma Medical Institute Bathinda and co-founder of Tattva Oncology along with Dr. Robin Khosa. He will be speaking on the in clinical outcome.
Thanks IMA team for giving me opportunity. Thanks IMA team for giving me opportunity to speak on this platform. We are running radiation oncology and doing all high procedure techniques like IMRT, IGRT with gating, SRS, SBRT. Dr. Robin Khosa is working with me as a medical advisor, and in place of me, he will speak on high procedure radiotherapy.
Hello everyone, I am Dr. Robin Khosa, currently Senior Consultant at Indraprastha Apollo Hospital and Chief Advisor at Pragma Medical Institute. So this topic is very important. I would thank the organizers for giving us this opportunity because radiation is one branch which is not, the MBBS students don't know too much about, and when we go into our super specialities, our link with this branch is probably the minimum and our understanding of radiation is to the least. Also, I would like to tell here that this is one branch that in last 20 years have seen the most developments among all other specialties of medicine. So while we started with radiation, it is now the era of precision radiation oncology, because initially what we were looking at was just tumor control, controlling the disease. But now is the era of ensuring quality of life. And how you can do is by not only controlling the disease, but also organ preservation. So how it is achieved, basically precision radiation oncology. Precision means you accurately find the tumor based on all your imaging modalities and define this tumor on these images, and then deliver a very accurate plan. Also keep taking into account the biology of the tumor when you radiate. Not all tumors have same sensitivity and same responsiveness. And also taking into account the real-time motion because of breathing and everything which is happening in our body. So while the original radiation was a static concept and just based on X-rays where you just say that these are the bony landmarks were used as a surrogate for your internal anatomy. Over a period of time, we saw 3D complex imaging technologies coming into picture, the CT scans, MRI, PET scans, and based on that, we could identify the tumor in real time on the machines and focus our radiations based on that, on those findings we see on the imaging technologies. So we shifted over these large. The intent was to reduce normal tissue toxification. Beam was conformed to the shape of the tumor. Organs and those radiation technology that we could do. The original image is of a simple type of a radiation, but when we do an advanced precision IMRT radiation, you could spare your carotids. So what it did, it reduced the long-term toxicities because of xerostomia, decreased saliva production, and difficulty in swallowing. Not only in head and neck cancers, in gynecological cancers, IMRT helped reduce the toxicity to the bowels. It reduced the toxicity to the bones. Patients' tolerance to treatment improved, and in turn it reflected into a better tumor control and survival for patients. A more advancements to IMRT is a VMAT technology where radiation is delivered at a much faster pace. So the areas of benefits we saw with this technology was head and neck cancers. It reduced the xerostomia and improved the swallowing functions of the patients in long run. Did not require randomized clinical trial to prove its benefit. It was accepted by the obvious benefit it was given. But later on, once it got incorporated, the validations were done for all the cancers, and it showed the benefits which are illustrated here. So it resulted in a better local controls, good overall survivals, and far less toxicities. So this is just one example of a radiation which were used to doing in the older era. You see what the final outcome. Patient is treated, but there is a whole lot of toxicities in the cavity and a parched tongue indicative of that the salivary function is almost gone. What it does, it reduces the swallowing functions of the patient. It increases the risk of caries, ultimately increases the risk of osteoradionecrosis happening in patients because of caries and all. So what newer radiation did, it limited the radiation to the smaller volumes and focused only on the tumors and helped reduce the toxicity. Again, another example of VMAT technology, how the surrounding bones and the normal tissue is protected in prostate cancers. This is not enough. Whatever we have seen till now is just a computer representation of what we intend to give to this patient. But what is delivered on the patient may not be exactly same what you have designed for this patient. So to ensure that whatever you have planned is delivered, we do incorporate a technology called IGRT, which is image guided radiation therapy. Now what it is, basically the machines have an inbuilt CT scanner. You run the scan before you treat the patient on of radiation to the normal tissues while the tumor is getting a certain amount of dose. But with the advent of IGRT, we evolved into a techniques called adaptive radiotherapy, that everyday monitoring and titrating the radiation dose based on the new tumor size what is nowadays practiced in most of the tertiary centers which have the skill to do these. Another very important thing where the revolution came into the picture is breast cancers. Why it is important? Breast cancer is now becoming the most common cancer in most metro cities. It is becoming very common in young population. Earlier we used to see only older women. So more younger the women, the risk, it is a more aggressive biology. So more aggressive biology means she requires more treatment compared to what older women would require. So many of the patients would require radiation therapy. Again, breast conservation surgeries has increased. Why? The cosmetic outcomes is what matters to the patient more, along with the disease control. So all patients of breast cancer, the axillary nodes are rated while we were in Apollo Hospital. This is what the heart gets. In the second picture you see when the patient takes a deep breath and then the radiation is delivered. The radiation is only limited to the chest wall and the heart is principally spared from major radiation doses. So also because of the enlargement of the lung, lesser portion of the lung relatively gets higher doses. So again, another concept of reducing the long-term toxicities in patients, especially now, as I said, more and more premenopausal women are getting breast cancers. So all these studies have substantiated the fact that how radiation helped. Now it has been said that even one single gray of lesser radiation to the heart results in toxicity reduced by 7.5% long-term risk of cardiomyopathy in patients with radiation-induced heart diseases. So this is how we have revolutionized. again, all these concepts are basically to reduce the long-term toxicities and ensure a better quality of life for the patient. Now, the latest concept which we have incorporated is a moving organ. A lung is continuously breathing, your diaphragm is moving, it is moving your liver also. So if you try to focus on, so this is how you see the continuous picture. You can see the tumor in the right lung. It is sometimes visible, sometimes not visible. So that is because there is a continuous breathing motion, and we have to localize this tumor. So what we can do is either like that second picture, the last right bottom picture, you draw the tumor in all the phases of breathing and treat a very large volume, or you freeze the motion in what particular phase and then give radiation. So what it does, tumor control will be excellent in both, but toxicity is what is going to matter here. And again, this picture will you show. Now this is how we deliver radiation to these patients. The patient gets radiation only when it comes in the path of the beam. Rest of the time the beam gets automatically switched off, which results in far lesser toxicity to the patient. So this is done by various technologies, and we call this as respiratory gating. Means we treat the patient in only one particular phase of breathing, and then the beam is fired only in this case. Or you freeze the motion just like breast cancers and then treat these patients. Now, till now we only discussed the concept of reducing toxicity. Now, SBRT is another concept where we not only reduce the toxicity, but we also improve the local control rates. Now, how it is done is basically, it acts as a slightly different from a conventional radiation therapy. We all have read probably somewhere that some tumors are radiosensitive, some tumors are radioresistant. So like sarcomas, melanomas are less sensitive to radiation, so they should not be getting radiation, right? But that concept is basically because of the conventional radiation delivery techniques of 2 Gray per fraction, where single-stranded DNA break happens because of this. SBRT technology basically works on the principle of example, in SBRT of the lungs, it has been a multi-continental trials were done. They couldn't accrue too many patients, but then the authors collated both these studies, and it was seen in stage T1, N0, T2, N0. The outcomes were as high as 90 to 95% over a period of 5 years, which actually was similar to the lobectomy in these particular cases. Again, the patients had excellent outcomes and good quality of life. Same is for hepatocellular cancers, a very common disease seen in this part of the country. Arrange a liver donor. So SBRT was given as a bridge therapy to control the disease for that particular point of 60% to 90% many patients. Then stereotactic radiation for brain mets, again local control as high as 80 to 90%. And in the era, other than lung, liver, spine, we have adrenal mets, oligometastasis, where we see excellent tumor controls by SBRT technology. Newer technology is proton therapy, currently only in 2 centers, Apollo Chennai and Tata Memorial Mumbai. It is a different technology, pretty costlier as of now, but will more centers come into, the technology will get a little more affordable. One important aspect I wanted to discuss is re-radiation. This is why local recurrence is a clinical reality now. In the older era, when you treated patients, there were some patients who relapsed. So many of the times we would just send them home telling them best supportive care, just take care of them. But now with the advent of these technologies, we are able to give patients re-radiation to achieve control and give them better life. So overall precision radiotherapy it reduced hospital visits, it has maintained systemic therapy timelines, it has improved functional outcomes and better quality of life. What are the limitations? The technology, access and the cost.
Thank you, sir, for that excellent and informative talk. Thank you, sir, for that excellent and informative talk. Now I request our respected chairperson to kindly felicitate our speaker. Now I would like to request Dr. Akhilesh Pathak sir to kindly present a token of appreciation to our respected chairpersons for guiding us throughout the session. Now I request my colleague to kindly take over the podium.
Person, but I have chosen this, selected this topic for the simple reason that we, the medical professions, need to be vigilant about the modern related to our encompass a variety of illegal activities where attackers gain unauthorized access to health-related data or systems. These include data breaches, unauthorized access and exfiltration of sensitive patient and healthcare provider information, then ransomware attacks, encryption of the hospital systems, and demand for ransom from healthcare institutions and professionals to restore the access, then phishing or social engineering, use of deceptive emails and messages to trick staff into revealing credentials, exploitation of vulnerabilities or misconfigured devices in hospital networks, then dark web sales stored on criminal marketplaces for profit, threats and extortion, individuals or organizations using compromised data as leverage. These crimes violate not only ethical principles of privacy and confidentiality, but why medical records are highly targeted and uniquely valuable in illicit markets. Because of the reason rich, personally identified information including health history, insurance IDs and demographic data, high resale value. A complete medical record can fetch significantly more than a stolen credit card number on the dark web. Potential for fraud. Such data enables identity theft, falsified insurance claims, unauthorized treatments billed to victims, and targeted extortion. A breach of medical records can thus lead to long-term privacy stalking, financial loss, false information claims, and serious emotional distress. Landscape of medical data cybercrimes in India. India's healthcare sector is rapidly digitizing through initiatives like the Ayushman Bharat Digital Mission, which aims to integrate patient records across systems. However, this transition has outpaced cybersecurity readiness in many institutions, leaving gaps exploited by cybercriminals. We have the current examples. AIMS ransomware attack, the All India Institute of Medical Sciences, one of India's leading medical research and healthcare institution, was targeted by a ransomware attack that encrypted crucial hospital servers and data in November 2022. The attack disrupted hospital operations and compromised access to e-hospital records that included patient histories and laboratory data. Cybersecurity researchers have attributed such attacks to sophisticated ransomware groups actively targeting Indian healthcare networks, including threats to leak or destroy patient data unless ransom demands are met. The Ayush Jharkhand portal data leak 23 in one of the major data breach incidents affecting Indian health data. Official Ministry of Ayush website for Jharkhand was hacked. Over 320,000 patient records, including after being a threat actor known as Tanaka. This breach also exposed hundreds of login credentials, some in unencrypted form, which facilitated further attacks and that private patient data from a Tamil Nadu hospital. Potentially around 150,000 records was being sold on dark web forums. The data set included names, guardian details, dates of birth, and doctor's details, allegedly sourced from a compromised third-party vendor linked to the hospital's digital systems. The employee. This highlights a key vulnerability. Many smaller hospitals become gateways to valuable patient data. Then serious CCTV hack in Gujarat hospital. Although not a traditional data breach of health records, in June 2025, two hospitals in Delhi, Sant Paramananda Hospital and NKS Super Specialty Hospital, reported their servers were hacked, resulting in breaches involving patient records, financial documents, and administrative files. Delhi police registered FIR. Financial documents and administrative files. Delhi police registered FIR under relevant sections of IT Act and are investigating the source. Under relevant sections of IT Act and are investigating the source of attackers. Now, why are cybercrimes impact individuals? Cybercrimes impact individuals and institutions in multiple ways, like privacy loss or identity theft, financial losses, trust deficit, legal and regulatory liability, operational disruption. Then legal framework and cyber security requirements in India. India governs cybercrime and data protection through several key statutes. IT Act 2000 criminalizes unauthorized access to computer systems and data theft, prescribing penalties and liabilities. Then DPDP Act 2003 establishes mandates for lawful processing, consent, data minimization, and stringent security safeguards for personal data, including health records. Under these frameworks, healthcare entities are expected to implement robust cybersecurity protocols, including encryption, multi-factor authentication, best practices for prevention and protection. The healthcare organizations can improve their cybersecurity posture by implementing strong access, multi-factor authentication, and unique credentials. Regular patching and updates reduce the attack surface by keeping systems quiet. Encrypting data at rest and in transit, employee awareness training, strengthen defenses against phishing and social engineering. Routine penetration testing simulate attack attached to identity security gaps. Incident response planning, prepare for rapid environment and recovery in the event of breach. To conclude, cyber crimes targeting medical records reflect the darker side of digital health transformation. India's healthcare ecosystem spanning public hospitals, private healthcare providers, insurers, and third-party IT vendors has experienced a range of data breaches, ransomware attacks, and privacy violations in recent years. These incidents highlight persistent security vulnerabilities and stress the urgency to comprehensive cybersecurity measures, regulatory compliance, and institutional accountability. Protecting medical records is not only about preserving privacy, it is about safeguarding human dignity, clinical trust, and fundamental integrity of healthcare delivery in the digital era. Thank you very much. Any question can be addressed to chairpersons. If they are the young people, they can better answer. Looking like. Thank you, sir.
I am Dr. Sunil Patel. मीटिंग होनी चाहिए कि किसने ये सिस्टम असेस किया, रेगुलर मीटिंग, और क्या क्या चेंजेस की. That should be regularly assessed. Then क्या changes की. That should be regularly assessed. Then there should be regular backup also. Backup is important. Then yearly security system should be audited. These are the things if रखें तो काफी protection हो जाती है.
Sure. Thank you, sir. Sure. Thank you, sir.
That most of the hospitals are outsourcing their data processing to the IT people. There are a lot of companies in Ludhiana, and I'm Dr. Gaurav Sachdeva, I'm past president IIM Ludhiana. So, sir, it's very difficult, as sir said, that they are this thing in the hospitals. And most of the hospitals have given it to the third party only.
Data is hacked, hospital authorities' responsibility is more with the hospital.
Certainly, sir, but we have already sharing our passwords, and every time a new guy is coming from that company, we have to give him the password. So
we negotiate the cost with the safety is compromised.
Exactly. So cost is the main distance.
And safety is compromised.
And AI coming in, so the data will be really, really difficult to conserve in our hospitals.
Thank you so much, dear. This is Dr. Ashish Shori from Ludhiana, the President IIM Punjab. The data we should always bear in mind for the next 10 years that the data is money, nothing else. You should not earn money, but you should be protecting your data. The biggest thing which is coming on with the small scale hospitals and the medium scale hospitals is the cloud computing. We take the softwares which are cloud based, their servers are cloud based, and you will suddenly find, you will not come to know, but your data will be available on the dark web or the deep web. And that may not be in your hospital's name. If your hospital's name is prominent, you have to sell it. The first and foremost thing for your basic Facebook, social media like that, the access should be very restricted, and rightly said by Dr. Katyal, it should be audited and supervised, may not be yearly, maybe once in a month. There should be a dedicated data auditing team with the hospital, which is around 50-bedded hospital. Less than that, it will be too costly. The maintenance cost increases. But cloud computing, definitely yes, you should be very careful. The company who is selling you the cheap plans at the peanuts, that is bound to sell your data. Those are the data gathering companies. Thank you so much.
So we are talking about the safety of the patient data. Now there is stall outside also the Ayushman Bharat digital mission. Now just like Aadhaar card, every patient will be having the health ID. मेरा क्वेश्चन ये है कि मान लो मेरे हॉस्पिटल में 50 पेशेंट देखता हूँ, मेरा वो डाटा मैंने आभा आईडी में डाल दिया। अगर वो मेरा डाटा मैंने सेव भी कर लिया, पर वो गवर्नमेंट के पास वो डाटा चला गया ना, वो चला गया, तो मेरा सेव डाटे का कोई फायदा ही नहीं है अगर वो वहां से लीक हो गया। तो क्यों है कि डाटा सेव होना चाहिए, सेफ रहना चाहिए? मेरा क्वेश्चन ये है कि मतलब इतना हमें क्यों उसके ध्यान रखना चाहिए?
There should not be any pointing finger towards us, the doctors. Maybe it is leaked by the government or the lawyer or the companies. What I understand.
Hello. Sir, with your permission, sir. सर इसके अंदर नुकसान ये है कि हम जो डाटा गवर्नमेंट के साथ शेयर कर रहे हैं, so government is responsible for its privacy.
Yes.
और अगर हमारा डाटा किसी unauthorized person के पास जा रहा है because of our lack of systems और किसी गलत एजेंसी के पास जा रहा है, that is wrong. ये फर्क है सर. वो डाटा गवर्नमेंट साइड पे दे रहा है और गवर्नमेंट has very good system, foolproof system, sir.
So I give you a simple example of postmortem report. Postmortem report it is confidential document. We hand over this report to the police. If somebody is having that report, not from us but from the police, it is a responsibility or police is the culprit, not the doctors. So that is the situation here also.
So I think this is one of
that is password protected, madam.
It's a quite interesting topic and so many from the audience. And what I think that right now we are in the process of digitization. So we are trying to adopt the online portals and all that. But definitely till now, except some of the institutes, we have not reached to that stage that we have to protect all these things. So definitely when we will be attacked by anyone, then the process will be done. So I think later on it will come. But yeah, all these are the stages we have to go through that. Thank you.
Thank you, sir. Thank you. Thank you.
Thank you very much. So thank you, Buller sir, for creating awareness and sensitizing the house about the cyber crime. I will just share one point. Like in our institute, we are using the firewall system to protect the data, and limited access is there. Like sir ने बोला कि laboratory वाले को सिर्फ lab वाले दिख रहा है, accounts वाले को सिर्फ accounts वाले दिख रहा है, सबकी limited access है, हमको वही मिल रहा है. Two things.
Thank you so much, sir, for your wholesome wisdom. Now I request the chairpersons to kindly felicitate Dr. D.S. Bhuller. Nextly, I request Dr. Sunil Katiyal to kindly felicitate our respected chairpersons.
We have now moved to our new session titled Urological Emergency in Clinical Practice and Management. To chair this session, we are honored to invite our chairperson Dr. Maninder Jora, who has MSc Urology at Delhi Heart Institute and Multispecialty Hospital, and Dr. Ch.S.
A very warm good evening to everybody. It's a matter of great honor and privilege for me, myself, Dr. Saurabh Gupta, to welcome you all to PIMACON-2025 in this session. Welcome, chairpersons, Dr. Maninder Jora, Dr. Chal. It's a matter of big honor for me to have you as chairpersons. Welcome, esteemed faculty from all parts of Punjab and national faculty. I won't be taking much time. I just have 18 slides. I'm not going to be very pragmatic or not going to be very theoretical. मेरी presentation बहुत basic चीज ਨੂੰ touch करेगी, that is urological emergencies. We all are clinicians, कोई orthopedician है, कोई surgeon है, कोई gynecologist है, but everybody encounters some or different urological emergencies. Now, what sort of emergencies can it be? You all know, कोई emergency आती है, we have to look for A, B, C, D, E. Airway, breathing, circulation. But as urologists, साडा दिमाग सीधा ABC तो सीधा U पे जाता है. Airway, breathing, circulation, then it comes urology for us. Now, the most common urological emergencies what we encounter in our routine is retention urine. आप कभी urine नहीं आ रहा patient, surgery सवेरे bleeding आ रही urine दे which patient, the relatives, patient, everybody is panicked. Then another common emergency is that physicians or whatever we are, stone pain. तिखा pain हो रहा है, patient मिल ही जाता है, औखा हो ही जाता है, vomiting करी जा रहा है, severe pain. Urosepsis, UTI, तांबा चढ़ के बुखार आना, यूरिन में जलन होना, obstructive uropathy, गुर्दे फेल हो जाना, पेशेंट का यूरिया क्रिएटिनिन बढ़ गया, गुर्दे फेल हो जाना, पेशेंट का यूरिया क्रिएटिनिन बढ़ गया, ट्रॉमा, सट लग गई, चाहे किडनी को चोट लगी, ब्लैडर को इंजरी हो गई, पेल्विक फ्रैक्चर हो गया, फीमर की हड्डी टूटी सी, नाल ब्लैडर इंजरी हो गई, यूरिथ्रा इंजरी हो गई, ब्लीडिंग हो रही है, एपिडिडाइमोर्काइटिस और टॉर्शन, एक्यूट स्क्रॉटम जिन्हों आप कहते हैं कि बच्चा घरे सीगा कहते एकदम गोली से सोजिश आ गई, एकदम अंडकोश में स्वेलिंग आ गई, स्क्रॉटम स्वेलिंग आ गई, 4 days gangrene of priapism. This is मोटा जो मैं 5-6 स्लाइड से डिस्कस करूंगा. Retention urine, most common in males is जो आती है आपकी नर्स आती है, क्योंकि आप नर्स को बोल भैया कैथेटर डाल दे, किसी को टेक्नीशियन को बोल देते हो, वो आती है सर कैथेटर का पाया सी यूरिन नहीं आया. Most common cause, yes, faulty catheterization. ज्यादातर उनका फोली जो हम देखते हैं कॉमन कॉल्स में विजाइना में डला होता है, यूरिथ्रल ओपनिंग उनको लोकलाइज नहीं हो पाती because of inflammation of senile atrophy and they end up placing a catheter in vagina. Meatal stenosis, especially postmenopausal females, diabetic postmenopausal, you may have meatal stenosis, and then clot retention common to both. Clots because of prostate or whatever. Then we move on to the next slide, that is gross hematuria. Bleeding in urine. कब होएगी? या तो prostate के कारण होएगी, या urethra rupture हो जाए, या sometimes कोई chronically catheterized patient है, patient pulling, पेशेंट शिफ्ट कर रहे थे, एम्बुलेंस में शिफ्ट कर रहे थे, स्ट्रेचर तो शिफ्ट कर रहे थे, आईसीयू तो वार्ड शिफ्ट कर रहे थे, कैथेटर पुल हो गए, डॉक्टर पहला तो ठीक सीगा, वो ब्लीडिंग स्टार्ट हो गई, बिकॉज मोस्ट ऑफ द एल्डरली और समटाइम्स लॉट ऑफ पीपल आर ऑन ब्लड थिनर्स, एंटीप्लेटलेट इफेक्ट का ब्लीडिंग जल्दी स्टार्ट हो जाती है. यूरिनरी ब्लैडर ट्यूमर इन एल्डरली वी शुड ऑलवेज थिंक ऑफ ब्लीडिंग फ्रॉम मे बी अपर ट्रैक किडनी से आ रही हो, या फिर पोस्ट पीसीएल जो हमारा स्टोन रिमूवल सर्जरी है उसके बाद हो गई हो, या कोई ट्रॉमा हो गया, चोट लग गई हो, या फिर डिरेंज कोएगुलेशन प्रोफाइल. ऑब्वियसली यू हैव टू लुक फॉर इट. देन मूविंग ऑन टू द नेक्स्ट एमरजेंसी कॉमनली एनकाउंटर्ड इन एमरजेंसी ऑल हॉस्पिटल. ਤੁਹਾਡਾ ਆਂਢੀ ਗੁਆਂਢੀ ਵੀ ਹੋ ਸਕਦਾ, ਰਾਤ ਨੂੰ 2 ਵਜੇ ਆ ਗਿਆ, ਡਾਕਟਰ ਸਾਹਿਬ ਤਿੱਖਾ ਪੇਨ ਹੋ ਰਿਹਾ ਫਲੈਂਕ ਦੇ ਵਿੱਚ, ਸੁਸੂ ਕਰਨ 'ਚ ਵੀ ਪੇਨ ਹੋ ਰਿਹਾ, ਐ ਲੱਗਦਾ ਸੁਸੂ ਉਤਰੂਗਾ ਹੀ ਨਹੀਂ, या किसी का यूरिन में जलन हो गई, ब्लड आने लग गया. So we should always think of renal colic, and renal colic is one of the worst colic. जैसे कहते हैं लेबर पेन सबसे ज्यादा दर्द करता है, एक डेंटल पेन सबसे ज्यादा दर्द करता है, तीसरा renal colic. ਜਦੋਂ ਬੰਦੇ ਨੂੰ ਪਥਰੀ ਦਾ ਦਰਦ ਸ਼ੁਰੂ ਹੁੰਦਾ, ਪੰਜਾਬੀ 'ਚ ਆਪਾਂ ਸਾਰੇ ਜਾਣਦੇ, ਬੰਦਾ ਕਹਿੰਦਾ ਮੇਲੀ ਜਾਂਦਾ ਸੀ ਜਾਂ ਪਾਸੀ ਲਈ ਜਾਂਦਾ ਸੀ, ਬੜਾ ਔਖਾ ਹੋ ਗਿਆ ਸੀ. It may or may not be accompanied with nausea or vomiting, and pain while passing urine or obstructive voiding. Obviously इमीडिएटली तो आपको उसका पेन रिलीफ करना है, एनाल्जेसिक देना है, सपोर्टिव ट्रीटमेंट देना है, वॉमिट कर रहा है तो वॉमिटिंग का ट्रीटमेंट करना है, एंड आरटी के लागे बंदा हजे भी मिल ही जाता है. इन दैट केस यू हैव टू थिंक ऑफ ओपियोइड्स लाइक ब्यूटाफेनॉल या ट्रामाडोल वगैरह की भी हेल्प लेनी पड़ती है. यूरोसेप्सिस, पाइलोनेफ्राइटिस, बिलीव मी दिस इज वन एमरजेंसी. आप कभी ना कभी अपने लाइफ में, आप चाहे स्किन के भी डॉक्टर हो, कदे ना कदे तुसी देखोगे जो पेशेंट आऊगा तंबा चढ़ के बुखार हो रहा होगा, पेशेंट वॉमिट कर रहा होगा तो बक्खी च हाथ नहीं लगा दूंगा ਤੁਹਾਨੂੰ. In that case you should always have a suspicion of pyelonephritis, that is कि किडनी में आपकी इन्फ्लेमेशन हो गई है. And there is a term called emphysematous pyelonephritis जो कि डायबिटिक्स immunosuppressed बंदे जो बहुत कॉमन होती है. I have very eminent endocrinologist sitting with me, Dr. Naveen Mittal ji. He must be sending calls to the urologist. So why diabetes, HbA1c 10 था, patient emphysematous pyelonephritis के साथ आया, तो 42% तक mortality है. That are Campbell quotes. अगर आपने इसको timely manage नहीं किया, you may end up losing these patients. Then pyocystis, that is pus in bladder. Obstructive uropathy, मान लो आपकी पथरी यूरेटर में अड़ गई या कहीं यूरिथ्रा में अड़ गई, तो आप एंड अप कर सकते हो किडनी में पस पड़ने से. पेरिनेफ्रिक कलेक्शन, क्योंकि किडनी एक बैग सा होता है, कई बार पस पड़ जाती है, यूरिन इकट्ठा होता रहा, कई बार किडनी फट भी जाती है, जिसको पेरिनेफ्रिक कलेक्शन या श्वास एब्सेस कह देते हो, कि श्वास के ऊपर कलेक्शन हो जाती है. इमरजेंसी मैनेजमेंट के बाद, एक बार सपोर्टिव ट्रीटमेंट के बाद, यू हैव टू गो फॉर अ डीजे स्टेंट, डबल जे स्टेंट, bypass the obstruction, or you have to place a pictate, percutaneous nephrostomy. This is one example of emphysematous pyelonephritis, kidney swollen along with air pockets. And yes, this is the coronal section, again showing perinephric collection. Then obstructive uropathy, back pressure changes. Maybe because of prostate, phimosis, urethral stricture, big bladder stone, malignancies, or maybe ureteric calculi, big renal stones. आपका यूरिन हो सकता है आगे ना जाए तो बैक प्रेशर मारेगा, पेशेंट पेन के साथ आ सकता है, अपनी प्रॉब्लम के साथ आ सकता है. ऑब्स्ट्रक्टिव यूरोपैथी में, इन दैट केस व्हाट हैपेंस, जब किडनी की ऑब्स्ट्रक्शन हो जाती है, किडनी अपना काम नहीं कर पाएगी, यूरिया क्रिएटिन शूट करना पड़ जाता है, समटाइम्स इमरजेंसी में कई बार आपको उसको हीमोडायलाइज भी करना पड़ता है. ट्रॉमा, रोड साइड इंजरीज, फॉल्स, ट्रैक्टर से हो गया, चूल्हा टूट गया, जिन्हें पंजाबी में कहते हैं, आपके प्यूबिक रेमा है, जो प्यूबिक रेमस है, ये आपके ब्लैडर को इंजर करते हैं. जो प्यूबिक रेमस है, ये आपके ब्लैडर को इंजर करते हैं. जब सट लगती है, डिस्ट्रैक्शन हो जाती है, आपका ब्लैडर और यूरिथ्रा ये दोनों ही अलग हो जाते हैं. दिस इज कॉल्ड पेल्विक फ्रैक्चर यूरिथ्रल इंजरी. ये जिन्हों पंजाबी च आपां कहने कि चूल्हा टुटन कारण पेशाब की थैली ते नलकी वक्त हो गई, अलग हो गई. पेशेंट के आप नीचे से कैथेटर डालोगे, कैथेटर भी नहीं जाएगा, क्योंकि आपका जो पाइप है यूरिथ्रा वो तो अलग ही हो गया ब्लैडर से. इन दैट केस कई बार ਤੁਹਾਨੂੰ शॉक ਨੂੰ मेजर मद्देनजर रखते हुए इमीडिएट सुप्राप्यूबिक सिस्टोस्टोमी आपको करनी पड़ती है. यहाँ से आपको अगर कभी भी लगे कि नीचे कैथेटर नहीं जा रहा, पेशेंट औखा है, सिक है, never desist or never hesitate from doing a suprapubic cystostomy. It's not a very difficult procedure. Even an intern can perform. ਤੁਸੀਂ ਜੇ proper catheter नहीं भी पा सकते इधरों पेडू राही, you can just take a 10 cc syringe. 10 cc syringe लेकर के आप उसका जो आगे needle है उसको आप direct perpendicular 2 cm above the pubic symphysis umbilicus की लाइन में आप सीधा उसको 90 डिग्री डाल दो, सुसु आना शुरू हो जाता है. एक बार जो पेशेंट का पेन है, कई बार कहते हैं ना कि पेशाब थैली umbilicus तक पहुंची हुई सी यार, इतना खासी पेडू तक का पूरा ब्लैडर पर आया ऐसी, तो वो आपका एक बार पेशाब एक बार बाहर चला जाता है. जो एक्यूट क्राइसिस है, इवन वे यू मे बी एमडी मेडिसिन, यू मे बी एमडी स्किल, बट एक्यूट क्राइसिस टाइड ओवर आप सारे नु करना आना चाहिए. एंड विद दिस बेसिक सिंपल सा मैनूवर, इट्स लाइक प्लेसिंग अ कैनुला इनसाइड योर वेन. आप सिंपल एक सूर्य को रास्ता आ जाएगा. जो एक बार ऑर्थोपेडिशियन का या आईसीयू इंटेंसिविस्ट का एक्सप्रेस है कि यार पेशेंट शॉक च है कि मैं गड्डी है नु यार, मैं तो फ्लूइड रश करना, मैं तो यूरिन आउटपुट का ही नहीं पता शॉक च कितना हैगा, बिकॉज़ यूरिन आउटपुट मॉनिटरिंग इज वन क्रिटिकल स्टेप ऑफ शॉक मैनेजमेंट. वी ऑल एग्री विद दैट. सो आप सुप्राप्यूबिक एस्पिरेशन कहते हैं कि आप सिस्टोस्टोमी नहीं भी कर सकते, एसपीसी नहीं भी कर सकते, तो उसे एटलीस्ट सुप्राप्यूबिक एस्पिरेशन कर दो. एंड द मीनवाइल ऑब्वियसली यूरोलॉजिस्ट इज ऑलवेज एट योर बैक टू हैंडल ऑल दीस थिंग्स. देन एक्स्ट्रा पेरिटोनियल रप्चर ऑफ ब्लैडर की, अब मान लो वी सी कॉमनली बंदा कहता राती पार्टी तो आ रहा सी डिग पिया, फुल ब्लैडर से डिग पैंदा, कई बार ब्लैडर रप्चर भी हो जाते हैं. तो कई बार आपको कैथेटराइज करने से भी एक्स्ट्रा पेरिटोनियल जो थोड़ा बहुत इंजरीज होते हैं छोटे मोटे ब्लैडर की, वो मैनेज हो जाती है कंजर्वेटिवली. बट अगर इंट्रा पेरिटोनियल रप्चर है तो 95% ऑफ टाइम्स यू हैव टू गो फॉर अ सर्जरी. आपको ब्लैडर कई बार रिपेयर भी करना पड़ता है. Penile fracture, yes, intercourse related trauma, though it's not a bony structure, but yes, it's hard as a bone. आप इंसर्शन का गलत हो गया, कुछ हो गया, आपको नहीं पता चला, आपकी इंजरी हो गई, and you may land up with a big penile swelling. And this is pelvic urethral fracture injury. आपकी जब urethra और bladder अलग अलग हो जाते हैं, this is how a penile fracture looks like. It's also known as eggplant deformity. बैंगन जैसा हो जाना, brinjal deformity हम कहते हैं कि सारा आपका जो ब्लड था उस समय जो कॉर्पोरा कैवर्नोजम में था, ये सारा बस फेशिया फाड़ के पूरा आपके स्किन के अराउंड आ जाता है. इट्स अ मेडिकल इमरजेंसी. ऑब्वियसली आफ्टर एक बार मैनेजमेंट करके देन यू हैव टू कॉल द यूरोलॉजिस्ट. नाउ मूविंग ऑन टू एक्यूट स्क्रोटम. बहुत सारे आप बच्चे देखेंगे जिनमें एक्यूट स्क्रोटम टेस्टिकुलर स्वेलिंग के साथ आएंगे. उस टाइम बड़ा डाउट होता है क्या ये टॉर्शन है कि एपिडाइमोर्काइटिस है. टॉर्शन मतलब टेस्टिस का अपने पेडिकल पे घूम जाना. ये एक एक्यूट इमरजेंसी है. इट हैज टू बी मैनेज्ड विद इन 6 to 8 hours. द गोल्डन पीरियड आई रिपीट इज 6 to 8 hours. बहुत से बहुत 12 घंटे. इट्स लाइक जब मैं अपनी मुंडी मरोड़ता था कितनी देर में जिंदा रहूंगा. नहीं, आपकी ब्लड सप्लाई चली जाएगी, यू विल एंड अप लूजिंग दैट टेस्टिस. टॉर्शन रूल आउट करना बहुत जरूरी है. बेसिक सिंपल टेस्ट है. जे बच्चा या डॉलर ने कोई भी एडल्ट भी आया कि कहता मेरे एकदम ना स्वेलिंग आ गई टेस्टिस से, पेन बड़ा तेज हो रहा है, वॉमिटिंग की सेंसेशन भी है, आप उसका टेस्टिस को स्क्रोटम को एलिवेट करके देखो, थोड़ा चक के देखो, जेदा ओदा पेन घट जाता है, वो एपिडेमोर्काइटिस है. रिमेंबर इन्फ्लेमेशन, ड्यूबर ट्यूमर, कैलर डॉलर, लॉस ऑफ फंक्शन कि जे कितने अंग च इन्फ्लेमेशन है आप स्लिंग पा देने कि भाई सोच घट जूगी. तो अगर उसका आप स्क्रोटम एलिवेट करते हो, पेन घट जाता, दैट इज इन्फ्लेमेशन, दैट इज एपिडेमोर्काइटिस. बट इफ द पेन कोई फर्क नहीं पै रहा, देन इट इज सस्पेक्ट. आप सस्पिशन रखिए टॉर्शन के लिए. एपिडेमोर्काइटिस के अलावा टॉर्शन भी हो सकता है. अर्जेंट उसका कलर डॉप्लर कराइए. जो उसके विच एब्सेंट ब्लड सप्लाई है, इमीडिएटली रश टू द ऑपरेटिंग रूम. ओके, मूविंग ऑन टू अनदर. यस, in immunocompromised diabetics, HIV, seropositive patients, sometimes you end up seeing such photographs. Now this is Fournier's gangrene. Fournier's gangrene क्या होता है कि आपकी एक तरीके की सेलुलाइटिस है, एक तरीके की गैंग्रीन है, नेक्रोटाइजिंग फेशियाइटिस है, जो कि आपके स्क्रोटम को शुरू होती है डायबिटिक्स में या इम्यूनोकॉम्प्रोमाइज में. ग्रेजुअली इट स्प्रेड्स इन द प्यूबिक रीजन एंड इट मे स्प्रेड टू योर लोअर एब्डोमेन. गैस गैंग्रीन भी बन सकती है. इट्स अगेन वन इमरजेंसी. अर्जेंट आपको पूरा ले ओपन करना है, डिब्राइडमेंट करनी है, एंड एक्सेप्ट फॉर टेस्टिस सब कुछ उड़ा देना उसमें. दैट इज डेफिनेटिव मैनेजमेंट. अनदर कॉमन इमरजेंसी व्हाट आई थॉट कि पैराफाइमोसिस. फाइमोसिस हमने डिस्कस किया. फाइमोसिस इज कि प्रीप्यूस पीछे नहीं हो रही है फोर्स के. पैराफाइमोसिस साडे को लोग कहते पीछे तो हुई सी हुण अगे नहीं आती. in uncircumcised males, especially Hindu Sikh gentlemen, बच्चियां से भी हो जाता है. क्यों हो जाता है? कई बार जैसे मान लो क्रॉनिकली कैथेटराइज्ड पेशेंट है, कैथेटर पवा के लाए बाहरों, पीछे होता गई चमड़ी, आगे करनी भूल गए, फिर क्या होता है, एक रिंग बन जाती है. ये जो रिंग है ईडिमा की, ये ब्लड सप्लाई को खराब करेगी, आपका ग्लांस नेक्रोज हो सकता है. तो इमीडिएटली रिडक्शन करनी चाहिए पैराफाइमोसिस की. हो जाती है ठीक है, नहीं तो यू मे एंड अप डूइंग अ सर्कमसिजन. आपको ये जो कंस्ट्रक्शन रिंग है इसको हटाना ही होगा. तो पैराफाइमोसिस, yeah, just the last slide. Now moving on to priapism. Priapism, yes, priapism क्या होती है? अगर 4 घंटे तो बाद, the timing is 4 hours. अगर 4 घंटे तो बाद persistent painful erection रहने के कारण होते हैं, जो कि इस टेबल में दिए हुए हैं. I won't go into much details. कुछ ड्रग्स भी होती हैं, तो ड्रग एब्यूजर्स को ये प्रॉब्लम बहुत आती है. ये 2 तरह की होती है आपके. एक तो होती है इस्केमिक और नॉन इस्केमिक. इस्केमिक प्रायपिज्म, अगर ब्लड सप्लाई कॉम्प्रोमाइज्ड है, आप अर्जेंट पेशेंट के पेपावरिन नॉरएपिनेफ्रिन का इंजेक्शन लगाना है. नहीं होगा तो आपको शंट बनाना ही पड़ेगा. आपको जो ब्लड आपके पेनिस में इकट्ठा हो गया उसको डाइवर्ट आपको करना ही पड़ेगा. अदरवाइज यू मे एंड अप लूजिंग में चला जाए. और समटाइम्स अगर परसिस्टेंट पेनफुल रहता है इस्केमिक, तो कई बार गैंग्रीन भी हो सकती है. Because
it was very nice presentation.
Thank you, sir.
You covered almost all the aspects. My question is regarding torsion testes. You have rightly said it should be done as early as possible. I want to know what is the role of Doppler. Can we go for surgery without getting Doppler? My concern is time, to save time. And second question is regarding contralateral orchidopexy. We should do in all the cases, or there are some criteria to select patients for that. Thank you.
Thank you, sir. Sir, torsion undoubtedly, अगर आपको clinical suspicion high है, तो अड्डा patient, क्योंकि ज़्यादातर बच्चे होंगे हैं, मम्मी पापा समझदार हैं, they understand. If they are ready, here मैं दोनों तक अल्ट्रासाउंड कराऊंगा, ऑलरेडी 6 घंटे तेरे हो गए हैं. अगर पहुंच the patient himself is understanding, they gave it a written consent in their own language, then you can proceed with that. It's like handling a blunt trauma. I am having a high suspicion hemoperitoneum हैगा, मेरे को ब्लड के टेस्ट तक भेजने का टाइम नहीं है, मैं डायरेक्ट लेके जा सकता हूं, उन्होंने स्प्लीनेक्टमी भी कर सकता है डायरेक्ट जाके. Similarly, you can do that. But because of too much of medico-legal hassles nowadays, it's always better to, because सारे इंस्टीट्यूट या एटलीस्ट शहर च अद्धे घंटे ते आजकल हो जाता है. अपने सारे अल्ट्रासोनोलॉजिस्ट आर वेरी फ्रेंडली, दे अंडरस्टैंड. सारी लाइना बाईपास करके नहीं है, टॉर्शन आई है, पहला देख लेना. दे ट्राई टू डू दैट. बट यस, इन केस रात 3 बजे है, नहीं टाइम मिल रहा है, यू कैन ऑलवेज गो हेड विद अर्जेंट एक्सप्लोरेशन एंड डिटॉर्शन. जो सेकंड पार्ट क्वेश्चन है सीगा सर कि शुड वी गो फॉर कॉन्ट्रालेटरल ऑर्किडोपेक्सी? ऑलवेज सर, ऑलवेज, बिकॉज बुक्स राइट 20 to 25% चांस ऑफ अगेन टॉर्शन ऑफ द कॉन्ट्रालेटरल टेस्टिस. जो बेल ट्रैपर डिफॉर्मिटी है साडी कि वे क्यों होया, आज सज्जी घूमी है, कल हो खब्बी घूम जे. सो ऑलवेज गो फॉर कॉन्ट्रालेटरल ऑर्किडोपेक्सी. दैट इज द रूल. इफ यू मिस इट, you may end up in a medico-legal tussle.
Exactly. I just wanted to reiterate what Dr. Saurabh said. Sir, these days, considering the availability of urologists as well as ultrasonologists, most of the urologists, qualified urologists, won't go for any radiology. Is around 16-17 years of age. And for contralateral, it is actually a medical negligence or medical negligence or orchidopexy on the other side in the same sitting. Whether this testis has been preserved or not. Even if it is a preserved testis, and you have to do orchidopexy on the other side. I think that would be all, and I thank Dr. Saurabh again for the very knowledgeable talk. Thank you, sir.
Thank you, Dr. Saurabh.
Any more questions? No. So thank you, Dr. Saurabh. Very energetic talk. Post lunch, सबका drowsy mood आपने खत्म कर दिया. Thank you so much.
I'm glad I could do that.
Thank you so much. Yes.
Thank you, Dr. Gupta sir, for your great and valuable session. Now I request our chairperson, Now I request Dr. Ravikant Gupta, MD Pediatrics, Senior Medical Officer, Civil Hospital, Talwandi Sabo, and Dr. Bhagwan Singh, past State President, Indian Medical Association Punjab, to kindly felicitate our chairperson as a token of appreciation. Now next session will be by my colleague.
Continuing the next session, I would like to invite the next chairpersons, Dr. Bharat Bhushan Jindal, leading physician of the Bathinda, and Dr. Sanjeev Mittal, leading physician of Moga, to kindly join us on the stage. Now I request our next guest speaker, Honorable Dr. Naveen Mittal, Professor and HOD of Endocrinology, DMC Ludhiana. He published 26 papers in national and international journals. Please welcome, sir.
In the absence of Dr. Sanjeev Mittal, I request our leading physician.
Diversity management. What is diversity? Diversity. Obesity means body mass index traditionally has been taken more than 25 kg per meter square in India. But now they are saying it might be more than 23 kg per meter square we should take the patient as obese in India. Diabetes and obesity, if together, they potentiate each other effect. They can lead to hypertension, dyslipidemia. They can affect the end organs like liver, kidney and heart. Patient can have chronic kidney disease, cerebrovascular accident, cardiovascular disease, peripheral vascular disease and MASH, that is fatty liver. It requires multifactorial intervention to control these people. What American Diabetes Association, this is what we follow. What they have told, if a diabetic person is suffering from coronary artery disease, the cardiovascular disease, GLP-1 receptor agonist or SGLT2 inhibitor. Simultaneously, if the patient is having chronic kidney disease or is having semaglutide is known to give the protection. What are the GLP-1? GLP-1 cells of the intestine and from the hindbrain, and it protects the body. It goes to the GIT and pancreas. From the pancreas, it releases the insulin and C-peptides. What are the GLPs which are available in the market? Delaglutide, semaglutide and liraglutide. Out of them, I would say semaglutide is the best studied. It has been extensively studied. It has got a half-life of 7 days. It has got 94% homologous to the GLP-1. I am going to limit my talk on semaglutide. GLP-1 receptor agonists help in the management of diabetes. How? You know that in diabetes there is insulin deficiency, there is increased glucagon, there is increased hepatic glucose output, there is decreased insulin effect. Semaglutide almost acts in all of them except on insulin resistance. It releases the insulin in a glucose dependent manner and inhibits the secretion of glucagon in a glucose dependent manner. What it means, if you give GLP-1 receptor alone, there would be no hypoglycemia. Insulin secretion would be stopped as soon as blood sugar falls below normal. Dr. Mittal, glucagon in a glucose-dependent manner reduces the energy intake and decreases the weight and decreases the postprandial lipids. American Diabetes Association has recommended it as a first-line therapy for the management of diabetes, who is for the control of blood sugar and for prevention of coronary artery disease and cardiovascular diseases and for prevention of chronic kidney disease. Why? It is once weekly dose which is convenient. It has been seen, it has been used in many patients on 38 million patient years. Does it provide a good glycemic control? Does it gives a good compelling weight loss? Does it provide kidney renal protection? This is what we are going to see. For a good drug therapy, it should control the blood sugar, it should give the good blood sugar, produces a good weight loss and protects against the kidney and liver damage. What has been seen? It reduces the glycosylated hemoglobin by 2.8%. It is a very significant weight, glycosylated hemoglobin lowering. Most of the oral drugs reduces glycosylated hemoglobin by 1%. Here it reduces by 2.8%. So if a patient comes to you with hemoglobin A1C of more than 9, you start with GLP-1 receptor agonist. There is good number of chances that its blood sugar would become normal even with this. When you compare it with GLP-1 with semaglutide with other drugs like other drug therapies, it fares better than the other liraglutide and exenatide as well. At 80% of the patients who are started on semaglutide achieves the glycosylated hemoglobin of less than 7%. So we have seen good glycemic control. What about the weight loss? It produces 7.6 kilograms of weight loss over 40 weeks mean average in a patient who are diabetic patient who are given this semaglutide, and this fares better than other therapies. As compared to SGLT2, metformin, insulin, the patient gains weight, but GLP-1 receptor agonist, patient loses weight, and semaglutide fares better than exenatide and liraglutide. 66% of the patients have at least 5% of the weight loss. And weight loss is more in the fat mass, less in the lean mass. In addition, we are given developing the dialysis or doubling of creatinine. So, about 25% chances of less death because of cardiovascular disease and because of renal failure. Less chances of getting again myocardial infarction. Less chances of going for the dialysis. I think so. This is a good drug. Cardiorenal protection is there. Why I have taken semaglutide? Because in next 1 month, I think so semaglutide cost is going to get reduced a lot. Till now, we are getting it around about 10,000 rupees per month, and its cost is going to be just 3,000 rupees per month from 1st of April. And a person who is not suffering from diabetes, if you give this drug, there is 21% mean reduction in body weight. And 33% of the patients have got reduction of more than 25% of the body weight. And about 20% of the body weight leads to reduction in waist circumference by 19 centimeters. So, what we see is with semaglutide a large number of benefits. Weight loss of about 21%, glycemic control of 2.8% glycosylated hemoglobin reduction. It is approved by US as FDA as primary prevention based on SOUTH trial. It reduces major atherosclerotic cardiovascular events by 26%, heart failure events by 69%. It improves the peripheral vascular disease symptom by 13%, reduces the kidney outcome by 24%, beneficial for liver, and overall reduces mortality by 20% in a person who is high risk to develop cardiovascular disease and renal failure. So, nutshell, just a carry home message, where you should use the GLP-1 agonists. In a person who is having body mass index more than 27 with comorbidity and body mass index more than 30 regardless of comorbidity. Preferable in a person who is having atherosclerotic cardiovascular disease or high risk to develop the cardiovascular disease. Having diabetic kidney disease or albuminuria, person is suffering from fatty liver. What are the checklists to be seen before you use GLP-1 receptor agonist? What are the adverse events? Adverse events profile? 20 to 30% of the patient have got GIT symptoms like nausea, vomiting, diarrhea, constipation, and abdominal pain. This can be decreased by gradually increasing the dose, starting from a minimal dose and gradually raising the dose, and asking the patient to restrict his meals. Small, frequent feeds. Avoid drinks like Coca-Cola, etc. Acute pancreatitis, there is an equivocal reports, but if the patient develops pain abdomen with raised amylase lipase, this drug should be stopped. Gallstones, very uncommon. Local site reaction can be seen but can be managed with antihistamines. If the patient is having proliferative or pre-proliferative diabetic retinopathy, this drug should not be used, might be worsening the diabetic retinopathy. Any diabetic drug which lowers the blood sugar rapidly, retinopathy. Non-arterial ischemic neuropathy, not convincing evidence. Acute kidney injury might be seen if the patient is having severe nausea, vomiting, diarrhea. Euglycemic ketoacidosis if patient stops taking carbohydrates totally. Suicidal and depression not confirmed yet. Do you think so? Patient requires monitoring with the amylase lipase and calcitonin? No. No routine monitoring of amylase lipase and calcitonin unless patient has the symptoms. If the patient has got chronic liver disease and chronic kidney disease, no dose modification is required. Not to be given in a pregnant and lactating female. Not recommended yet. If the patient wants to get pregnant, 2 months before the planned pregnancy, these drugs should be stopped. If the patient is taking oral contraceptive, ask the patient to shift to the barrier contraceptive because absorption of these drugs might be inhibited because of gastroparesis. So what we have seen, semaglutide gives a powerful glycemic protection, glycemic control, has compelling weight loss, gives good cardiorenal protection, once weekly dosing. With this, I conclude my lecture. Thank you.
Your prescription is not complete, as well as GLP-1A. Thank you very much. We will not take any questions because of paucity of time.
Dr. Dhingra is an orthopedician, that's why he's asking. It's a very good question. It is about orthopedician. Person who is obese, not suffering from diabetes, having osteoarthritis, can you prescribe GLP-1 receptor agonist? Yes. I have told it does not cause hypoglycemia given alone. So these drugs are recommended for a person who is not suffering from diabetes, just having obesity to reduce the weight. These drugs are recommended very much. For
any complications if glycemia or any?
These drugs given alone cannot cause hypoglycemia. They can be given in a non-diabetic patient who is obese or who is having osteoarthritis, having MASLD, having cardiovascular disease, not a diabetic. These drugs are recommended.
I am Dr. Pawan Nigra, I am a patient in Ludhiana, and Dr. Nain is my batchmate.
But important caveat is you must educate the patient for resistance exercises because if he lose weights, the sarcopenia will be there in presence of osteoporosis. It may become very dangerous. So resistance exercises to maintain lean body weight is real important in your patient.
So any questions or can we end the session? Okay. Thank you.
Thank you so much, sir. Your valuable perspectives will certainly guide us in improving patient care. Now I invite our chairpersons, Dr. Rajendra Sharma, past state president IMA Punjab, and Dr. Sunil Katyal,
I would request our chairpersons to felicitate speakers, sir. Naveen, sir.
up to motivate the people to do exercise and change their lifestyle. So my request is to the physicians that we should inculcate this habit of lifestyle change in the population, which is putting us in a crisis of health. We are having overburden with the kidney disease. We are overburdened with Dr. Vittal is an example of this. We need to change the outlook in the medical community. It is, if you see, I think there are very few persons who can be seen fit in our gathering also. He is one of them, right? So we have to be role models for the community to change this outlook so that we can have the medical professionals who will be able to say that you should become fit. So you should lead by the example. Dr. You can count only 4 or 5 persons in whole Punjab. This is the problem. We are having less than 1%. So our community is the most unfit and is having the burden of these diseases. So these conferences are such stages from where the message should go that we should change the outlook of the community first.
Dr. Saab, you have taken a very, very relevant point, because now the focus, basically I call it pharma mafia. Pharma mafia is projecting these drugs as, a magic bullet. But mind you, you see the all film celebrities on screen. Oh, bude lagan lag jande hai oh. So if you go with lifestyle modifications, most of the people will control weight. Only thing is they should continue with lifestyle modification, otherwise you will regain weight. And with these drugs you will lose fat as well as lean body mass. That is why resistance exercises are a must with these exercises, these drugs. But if you go for resistance exercises, before you take drugs, you will lose weight. So जेड़ा कुछ बाद च करना वो कुछ पहला कर लो, नाले पैसे बचेंगे, नाले health होगी ठीक. I 100% agree with you, sir. There is no controversy about that.
So our focus should be to do the lifestyle modifications and keeping the muscle mass. We should avoid sarcopenia. So that is only with the resistance exercises. That is lifting weights, own body weight exercises, high protein diet and mobility, which can be walk, which can be cycling, which can be running. That is your take. Thank you very much.
Thank you, sir, being so insightful. We should move to the last topic of this day 2. Please come.
Now for the final scientific presentation of this session, let's welcome our respected chairpersons, Dr. Bhola Singh and Dr. Anand Bansal. Both are leading pulmonologists of Bathinda. Nextly, I would like to welcome our guest speaker, Dr. Avneet Garg. He is Professor and Head Pulmonology at AIMSR. Sir will be addressing us on the topic Idiopathic Pulmonary Fibrosis. Please welcome, sir.
So good afternoon everyone. For next 15 to 20 minutes I will be presenting an overview of idiopathic pulmonary fibrosis. It is one of the most common interstitial lung diseases that we encounter in our real clinical practice. So this is the outline of my seminar. We will have a introductory slide and then we will discuss briefly about the factors, and then we will see how a patient with IPF clinically presents and how we diagnose the patient with IPF. And then we will discuss various aspects of the treatment. What are the antifibrotics available? What is the evidence behind them? What is the efficacy, dose, side effects, and whether there are interactions with various drugs, and how we do manage the side effects. What do we do if patients are having already a liver disease or kidney disease, and how we go with the combination of these drugs. And in the last, we will have a brief discussion about the new additions that have come up in last 6 months to 1 year, and then we will conclude it. So to just start with, what is idiopathic pulmonary fibrosis? As the name suggests, it is idiopathic, means of unknown cause, and it causes pulmonary fibrosis, means irreversible lung fibrosis that causes a permanent decline in the lung function. This permanent decline in the lung function is most important thing to understand, because once the patient comes to you, there will be some permanent decline in the lung function, and your aim will be to prevent the further deterioration rather than to reverse that lung function that can't be done at that point. So what is the impact of IPF in our society? If we see the incidence and prevalence just ranges from 10 to 100 per lakh population, although it seems to be a rare disease, but it is not a rare cause of death. So there are two ILD registries, two famous ILD registries published in India in last 10 years, and we all know that one was by Duria et al. From the PJ group, and second was by Sikru Singh from the Jaipur. So both these registries have shown that in India, IPF, idiopathic pulmonary fibrosis, is one of the most common ILD, and it stands as just say that patient started having dyspnea for last 6 months associated with dry cough, and rarely there will be any sputum unless there is significant traction bronchiectasis, and rarely there will be any systemic symptoms in the form of any fever, weight loss, or myalgia, etc. When we will see typical basal craps, and if we note that those PLC or 6-minute walk test and lung volume to document the lung function, because that will have a prognostic implication also. We can repeat the lung functions in follow-up at 6 months, 3 months, or at we can repeat the lung functions in follow-up at 6 months, 3 months, or at 1 year to see how lung behaves with the treatment or without the treatment. Diagnose the patient as a pattern of definite UIP, so there will be a probability of more than 95% that patient is a case of IPF. And if on the CT the pattern is suggestive of probable UIP pattern, there is still chances of 70 to 90% that a patient is a case of IPF. But if it is indeterminate for UIP, the chances are 50% roughly, and if the CT features are suggestive of some alternate diagnosis, then there are only 10 to 30% chances that patient is having IPF. So from the CT pattern, broadly, if the patient is having definite UIP pattern or probable UIP pattern, you can safely label the patient with a good confidence to be a case of IPF, and you can start the treatment directly. So you need to have a good CT reading, or you need to discuss the patient with your radiologist that what is the pattern, is it definite UIP or probable UIP, or it is something else, or you need to go for further investigation. Because if it is definitely UIP or probable UIP, you need not to go for any further diagnostic tests. So after we have diagnosed a patient to have a definite UIP pattern on CT chest, does it mean it is IPF only? So a UIP pattern on CT chest never means it is only IPF, because UIP pattern can be there in many other diseases. So what are the other diseases? We need to rule out CT-related ILD. We need to rule out any hypersensitive pneumonitis. We need to rule out if there is any ILD related to the occupational exposure. It can be inorganic or organic, or there can be some exposure to the radiation or drugs, or there can be some genetic component also. So if you diagnose a patient with UIP pattern, you confirm whether there is any alternative cause of UIP pattern in the form of CTD, hypersensitive pneumonitis, or occupational exposure in inorganic or organic. If it is not so, then you can safely label the patient to be a case of IPF, that is idiopathic pulmonary fibrosis. So what is the role of lung biopsy? So we already discussed if on the CT it is definitely UIP or probable UIP, you need not to go for any lung biopsy. But if it is indeterminate for UIP, or there is some alternative diagnosis, and you still think that there is
a good possibility of IPF or UIP pattern, then you can consider the patient for lung biopsy. And among the lung biopsy, we have the two options. Either we can go for the open lung biopsy, or we can go for the transbronchial cryobiopsy. Nowadays, the transbronchial cryobiopsy is the trend because it is much safer for the patient. So now, after the lung biopsy or after the CT, we have diagnosed the patient, we have labeled the patient to be a case of idiopathic pulmonary fibrosis. So now what about the treatment? So the primary treatment, the drug therapy, primary drug therapy should be an antifibrotic that we will discuss in further slides. Other than the drug therapy, we always need to remember that there are options of oxygen therapy, vaccination, patient education, palliative care, rehabilitation to address the comorbidities, and in the last lung transplant. These all options should be in our mind when we are seeing a patient of IPF in our clinics. So among the drug therapy, that is primarily antifibrotics. If we see how the IPF treatment evolved in 2008 guidelines, the treatment was primarily steroid plus azathioprine. Then there was a famous Interventional trial when it was seen that if you add an acetyl system with steroid and azathioprine, it would be better. Then there was a landmark trial, pencil trial, which showed that all these combinations is a rather harmful for the patient. So this combination was then stopped to be prescribed in the patients of IPF. Then there were many trials to see if there is any effective drug. All these trials were negative trials. And then finally, in 2008, there came pirfenidone, and in 2014, there came nintedanib. So there are major trials that just led to the discovery of pirfenidone, and nintedanib was capacity trial, ascent trial, tomorrow, and impulse trial. We won't go into the details. So the first drug is pirfenidone. So we primarily have two antifibrotic drugs, pirfenidone and nintedanib. So first drug is pirfenidone. So how it acts? It reduces fibroblast proliferation and collagen production stimulated by tumor growth factor beta. So we won't go into this pathogenesis. We will see how we go ahead with the pirfenidone, how we start the pirfenidone, how we escalate the dose. Usually we start with the dose of 200 mg TDS, and over a week or 2 weeks we try to increase it to 400 mg TDS, then 800 mg, 600 mg TDS, and then 800 mg TDS. And our target dose is primarily 1800 to 2400 of pirfenidone in a day. Going for last 1 year, 6 months. So you always think that this is just a placebo dose. If you want to treat your patient with pirfenidone, at least try to get too close to 1800 or 2400 in a day. So second drug is nintedanib. So how does it act? It is a tyrosine kinase inhibitor, and it reduces the fibrosis by various mechanisms that we won't go into detail. But the dose is very straightforward. It is 150 mg BD, and we directly start with the 150 mg BD. That's a major advantage of the nintedanib over pirfenidone. So then there are many trials for pirfenidone and nintedanib. The major RCTs that published in very blue journals of what was the key message from that trials? We won't go into the details of trials, but what was the key message? The key message was that antifibrotics, either pirfenidone or nintedanib, do reduce the decline of FVC by about 50 to 60%. There is a reduction of acute exacerbations, and there will be a reduction of lower all-cause mortality. So one thing you need to remember that a patient with IPF will worsen with time. His or her FVC will decline with time. These drugs are just decreasing that decline. They are not stopping it, they are not reversing it. So that decrease of that decline is by the magnitude of 50 to 60% by either of the drugs that has been seen among all the trials. So what are the side effects of pirfenidone? The pirfenidone primary side effects are either GI or then rash and photosensitivity. Among the GI side effects, we see the nausea, the most common. Others should be diarrhea, abdominal discomfort, dyspepsia, and anorexia. And what about the nintedanib? Nintedanib, also the side effects are primarily GI in the form of diarrhea, nausea, vomiting, and elevation in the liver function test. So other than this, we always are not that vigilant about the drug interactions of these drugs with the other drugs that are already going with the patient. So we need to remember these drug interactions. Likely, if your patient is on pirfenidone and patient is simultaneously receiving ciprofloxacin, then ciproflox will reduce the exposure of pirfenidone or will reduce the dose of by 1/3. So the effective dose will be going. So if the FVC is 20%, 30% should be. So if the FVC is 20%, 30% should we add antifibrotic, or if the FVC is normal, more than 90%, should we add antifibrotic? Question. Pirfenidone, 2400. We have discussed that the ideal dose is 2400. Can we give lower dose? We have discussed that the ideal dose is 2400. Can we give lower dose? And nintedanib, can we give 100 BD? So there are again many trials. They have compared the lesser doses with the optimum doses. So the main crux is, if you give the optimum dose, the effect will be high. If you give the lower dose, the effect will be significantly less. So you try to escalate the dose to maximum significantly less. So you try to escalate the dose to maximum tolerable dose. If pirfenidone, it should be 2400, and for nintedanib, it should be 150 BD. So our next question is, when to stop the antifibrotics?
Dr. Lee, can you please make it?
Okay, sir. So just 2 or 3 minutes. So when we should stop antifibrotics? So antifibrotics are primarily for whole life. So if a patient of IPF is an antifibrotic, he will be on antifibrotic for whole life. So what is the recent? Is there any role of combination of drugs? Yes, there is a role of combination of drugs. We can add pirfenidone. We can. Decline was even better when antifibrotics. So there are some new drugs. That is randomilast that has been approved by FDA, yet to be launched in India. And then there are some preclinical studies of inhaled pirfenidone. If it comes in market, that would be a better choice in the form of tolerability of that drug. So to summarize, IPF is a dreadful disease and early diagnosis is must, so that you can start the treatment early as possible.